as established by the legislature and the governor of Maryland. Today is February 20th. The time is currently 2:05 p.m. And my name is Boris Lushniak, and today I serve as the presiding chair of this commission meeting. I'm joined by my co-chairs, actually only one co-chair, Drew Brewster is not able to be here. Oh, she is on. Okay, so she's on, just not here. But here next to me to my right is Oluwatosin Olutayu. Summary of legislation. The Maryland Commission on Public Health was established in 2023 to study and make recommendations to improve Maryland's public health system. This is a 16-member body comprised of local health officers, academic partners, thought leaders, and legislators. The Maryland Department of Health is represented by the Deputy Secretary for Public Health Services, the Deputy Secretary for Behavioral Health, and the Director of the Office of Minority Health and Health Disparities. Many additional leaders and professionals are contributing to the Commission's 5 work groups, which are, these work groups will explore 5 key subject areas relevant to the mission. They include funding, governance and organizational capabilities, workforce that we'll hear from today, data and information technology we'll hear from today, and the communications and public engagement work group. The goal is to ensure the public health system is designed to help all Marylanders achieve their best health and a lifetime of wellness. Meetings are held monthly and streamed online, and for more information about our meetings, please visit our current website and the web address. I have the old one here yet. What's the new web address?
health.maryland.gov/COPH.
Okay, health.maryland.gov/COPH. This is a public meeting, and we have followed the requirements of posting a notification of this meeting. This meeting is being video recorded. By your continued participation in this meeting, especially those who are on the airwaves, you consent to the video recording of this meeting. We ask members of the public who may be attending to mute their microphones during this session. This meeting does not, I'll repeat again, does not include a time period for public comments. We will not be monitoring the chat function during the meeting. We encourage public comments, however, and please send them to our email at Maryland or md.coph@maryland.gov. That number again, md.coph@maryland.gov. We also ask members of the commission to mute your microphones when not speaking. Please use the raise hand function to indicate that you wish to speak, and you will be recognized. Individuals who serve on the commission are subject to Maryland public ethics law. All have confirmed their agreement to this in their applications and listed any conflicts of interest. Attendance requirements are posted and outlined in State Government Article Section 8-1501. And so we will take a time period for us ultimately to look at attendance here today and to assure that we have a quorum. This does not apply to the ex officios in terms of a mandatory attendance. I will now ask Shane to conduct the roll call of the commissioners. Shane, if you will.
When I call your name, please respond with here or present. Delegate Heather Bagnall. Camille Blake Fall.
Present.
Christopher Brandt. Mina Brewster.
Here.
Dean Drummond.
Here.
Senator Clarence Lamb. Matt Levy.
Here.
Benjamin Chin on behalf of the Deputy Secretary for Behavioral Health.
Present.
Boris Lushniak.
Here.
Nilesh Kalyanaraman.
Present.
Oluwatosin Olutayu.
Present.
Fran Phillips.
Here.
Laura Rothman.
Present.
Nicole Rochester.
Present.
Michelle Spencer.
Present.
Alan Twigg.
Here.
We have a quorum.
We have a quorum. Thank you. The agenda for today's meeting has been posted and distributed to the commissioners. Are there any comments on today's agenda, which I'll admit is stock full of not only a guest speaker that we're very excited to hear from, but also deep dives from two of our work groups. There's a lot ahead of us here today, so brace yourselves. Any comments on the agenda? If there are no comments, I ask for a motion to approve today's agenda.
So moved. Second.
Second?
Second.
Okay, we have a second. Let's move ahead then. For vote, all those in favor of today's agenda, please say aye and raise your hands on the screen. We'll monitor.
Aye.
Aye.
Great. Anybody against today's agenda? Anyone abstaining? Okay, we have accepted today's agenda as posted. We also have minutes from the previous meeting, which was held on January 23rd. They were posted and distributed. Any comments on the minutes of the last meeting? If there are none, I ask for a motion to approve the minutes.
I move.
Okay, Tosin moves. Second. Second from Matt. Let's all vote. All those in favor of the minutes from the January 23rd meeting, please say aye or raise your hands on screen. Anyone against? Anyone abstaining? We have accepted the minutes from last meeting. It is with much excitement that we welcome someone we've been trying to book for a while. You know, oftentimes when you have famous people out there doing incredible things that are good for the state of Maryland, it takes a while to bring them here. But we really wanted to get a special perspective. And so I'll allow Tosin to introduce our guest speaker today.
Thank you so much, Boris. Today, we have Secretary McCoy. We're so pleased to have you join us today. Thank you so much for taking time out of your busy schedule to be here. Secretary McCoy is the Maryland Department of Environment Secretary. She was confirmed as MDE's 11th secretary in March 2023. Prior to that, Secretary McCoy was Undersecretary of the California Environmental Protection Agency, a lifelong resident of the Washington, D.C. area. She worked in the federal government for 30 years, spending half of her career as operations administrator and leading large organizations with billion-dollar budgets. Midway through her career, she transitioned to managing policy issues in the energy and environmental sector, holding senior executive positions at both the U.S. Department of Energy and the U.S. Environmental Protection Agency. Secretary McCoy was Chief Operation Officer and Deputy Assistant Secretary at DOE in the Office of Fossil Energy. At the EPA, she served as Assistant Regional Administrator in Region 9, San Francisco. With a broad and diverse background in public sector, working for 6 executive branches of government, the legislative branch of government, and serving as a fellow for United States Congressman, Secretary McCoy uses her experience to lead MDE. She prioritizes several initiatives, including ensuring that Maryland is well positioned to meet its aggressive climate goals, strengthening environmental protection efforts by ending systemic environmental injustices, restoring and protecting the Chesapeake Bay, and leading with the purpose of achieving organizational excellence. Please join us today. Thank you.
Thank you, thank you. Just here's okay to sit.
Oh, that's
Okay,
perfect.
good.
Yeah, we have a microphone that's
Okay.
behind you.
Oh,
So,
perfect.
and we'll oftentimes hear from the group if we're not projecting well. So,
Okay, excellent.
Yeah.
Well, thank you so much for having me here today. It's really, truly my pleasure to be here and talk about some of the things that we do, or a lot of the things that we do at the Department of Environment. I do want to just reflect for a minute and just talk about what I've been doing since I became the secretary about 2 years ago. I have visited so many communities here in Maryland. I have witnessed firsthand some of the communities that have been really hit hard by flooding and pollution. I personally met with residents, some of which who lived in their communities literally for generations. And I've heard their stories about how they've been left behind for years and years and continue to be left behind. In Baltimore City, residents often face basement backups when public sewer systems clog and overflow. I'm dealing with that now, and it has been a long issue. Floodwaters are carrying sewage into their homes. These are real issues, real things that I have to deal with every single day. These incidents cause property damage, and they raise very serious long-term health and environmental concerns for us at Maryland's Department of the Environment. No one should ever have to deal with sewage in their home. It's unacceptable. The fact that I have to fight about that and get it straightened in Baltimore City is just something that really makes me realize how important the work that we do. These citizens are rightfully concerned about bacteria in their water, mold growing in some of their homes, and potential ongoing respiratory issues. These conversations remind me every single day that when we are addressing environmental issues, we're not only protecting the environment, but we are preventing public health crises as well. And this is why my agency, a lot of people say, well, you're the Environmental Protection Agency. And I say, yes, we are. But we're also the Health Protection Agency as well, because they go hand in hand. Okay, we have slides up. So the second slide. I wanted to just start by talking about the role that we have in protecting the environment as well as health for all Marylanders. Our mission is to protect human health by ensuring that we have an environment that is free of pollution in air, land, and water. And no, we're not healthcare providers, but we do have a similar role in caring for the health of all citizens because we are protecting the environment. Our job is to protect health and reduce health-related complications that are caused by unregulated environmental issues. We are working to support the prevention of illnesses that are related to environmental factors. That is our job. That is what we do. The one important focus of our work is to ensure that Maryland's water resources are safe, clean, and reliable for drinking, recreation, consumption, and of course, all of this directly impacts public health. We regulate and oversee public drinking water systems to protect communities from contaminants. And I'm sure you all have heard about PFAS. That's one of the main areas for which we're dealing with now. Bacteria, nitrates, you name it. We're responsible for protecting water in that way. This is how, obviously, we're making sure that the water that's coming out the tap is clean. Our work also includes monitoring and enforcing water quality standards to prevent waterborne illnesses, protect recreational waters, and safeguard seafood by managing those pollutants, and by regulating the wastewater treatment plants, stormwater runoff, industrial discharges. We are helping to prevent pollution that can threaten public health. We also have a critical role in responding to water-related health, public health emergencies, including contamination events, some of which I just talked about, infrastructure failures, and climate-driven risk to water systems. We do collaborate, we partner with local and state and federal health agencies really daily. We want to make sure that together we are mitigating threats and we're protecting the vulnerable populations, and we're supporting communities that are facing drinking water challenges. Again, all these things I hear about and deal with every single day. Our efforts to restore and protect the Chesapeake Bay not only improve water quality, but it also reduces harmful algal blooms as well. This is also how we ensure the long-term sustainability of Maryland's aquatic resources. And through science-based regulation, environmental stewardship, and community engagement, we remain committed to ensuring that everyone has access to safe and, again, clean water. And because, again, I think public health really does start with clean water. We also protect the air that we breathe, Of course, by regulating pollution that's caused by the modern world and all the things that are going on with industry. And so that's one of the main things that we do as well. Climate change is so important to address urgently because it really does create a critical threat to the health of humans. Disasters that we see every single day cause health issues and deaths by millions across the country, and a whole lot of deaths in Maryland that you may not even hear about. So climate change is real, and that's why that's one of the main priorities that we're dealing with in my agency as well, which is why the Climate Solutions Now Act is so important for us to take seriously and do what we can to reduce greenhouse gas emissions in Maryland. We also deal with many other environmental and health issues, such as lead poisoning. That's another area. The health of our children is so, so important. That's one of the main areas for which we work with the health departments as well, and NGOs. We want to make sure our children are not exposed to lead. A lot of the older buildings, as you know, have lead paint in them. That comes to us. You have little children, as you all probably know, who are picking away, eating the paint when they're in their bedrooms at night. And we had an incident not too long ago where a child ended up in the hospital for a long time. And so these are just the many issues that are so important to environmental protection and the reason why we do what we do. When we do our jobs right, I believe that we make it easier for health professionals to do their jobs. We also think about the health of Marylanders who are in those areas that I mentioned before that are historically left behind. And that's also why when we have access to health data, it is so important for my agency, because that's how we can look at the environmental pollution impacts, how it's impacting the health of those individuals in those communities, again, that have been left behind for so long. We do have a tool that's called the Environmental Justice Screening Tool. I hope that you all have looked at it. You're able, when you look at that tool, you're able to see exactly what's going on in those neighborhoods. And it's the health data that really helps us identify and understand the health impacts that are associated with environmental issues, which is why that tool is so important. The next slide, please. Climate change, as we know, is not a future problem. It is a problem today. More flooding means more contaminated water and damaged infrastructure. More heat waves mean more heat-related illnesses, especially in vulnerable communities, as I talked about. More wildfires, of course, more in California and Canada as well, where we had to deal with poor air quality. All of these issues that we're dealing with today is because of climate change. We are really working to strengthen Maryland's preparedness. We need to be more resilient. We need to ensure that those communities are ready when a disaster strikes. We do have the Office of Emergency Preparedness and Response. They are focusing on planning for those emergencies, such as hazardous material spills and natural disasters. Again, a lot of these things are happening a lot of times when we're asleep. We get calls, an oil spill, a truck turned over. I think I probably get those calls every single day. So my emergency response team is out making sure that we're protecting the environment when those things do happen. I'll give you an example. When the Francis Scott Key Bridge collapsed, my folks were right there. Immediately, I got a call at 1:30 in the morning. I was not even in the state, and I had to fly back ASAP to get here. And that's just how involved we are when there's a natural disaster or any kind of disaster. I want to also mention that my agency provides grants for smaller and rural jurisdictions to get the technical support that they need for projects that they want to do, particularly projects for drinking water issues and when they want to protect against flood risk. So we do help with technical assistance, and we do give those grants. Dams, there's another, that's another area that we don't really talk about enough, but they are really critical to the health and safety of all of us. There are so many dams in Maryland, private dams around the state that are really on the verge of failing. And it is scary for me. We every year we look at those dams and we inspect them, but some of them we're so afraid of, because if a disaster happens, you're talking lives gone in Maryland. And so that's one of the areas that you'll hear me starting to talk about a lot, because we do need to make sure that private dam owners have funding so that they can prepare those dams. And because we realize that a lot of these private dam owners do not have funding, I think it is our responsibility for the state, in terms of the state as well as MDE, to make sure that we have funding available to help. So that's one of the areas you're going to hear a lot from me in the public talking about dams. The next slide, please. I think most of you probably know that our governor is laser focused on making Maryland more competitive. And I want you to know that implementing our environmental initiatives, including the climate plan, really does mean we're going to have a better economy. My job is to reduce red tape while also, standing very firm when it comes to environmental protections to protect people. We need to have a skilled and knowledgeable workforce, because that, again, is the backbone of effective environmental stewardship. We can't tackle these challenges without people who do the work every single day. The governor has shown his commitment. He put aside $180 million in the current budget for solar installations, for example. When we do that, those are more jobs, more green jobs. The governor also put $90 million aside last year. Again, more jobs. When we're looking at capital projects or just any kind of green projects, we just have to remember, it's not just about environmental protection. It is about the economy. The next slide, please. I also like to remind people that my agency is also about science and data. And so it's just really a part of everything that we do. We have a robust IT infrastructure, which is really essential for us in our decision making, and we want to make sure that we have efficient operations. I know you talked about that earlier in terms of my priorities. Being efficient is important. I've heard complaints across Maryland about we need to do a better job in processing permits, because neighborhoods and communities and everyone's really expecting MDE to be more customer oriented and making sure that we're speeding up the process. I want you to know we are doing that. We're modernizing all of our systems. And I think you're going to see some real improvements in terms of how we get things done. Next slide, please. Partnership and collaboration. Environmental health isn't something that the government or even I can do by myself, right? It's a shared mission across all the agencies and communities. The local health departments are critical partners with my agency, and I at least daily, my MDE, a couple of my organizations speak with the local health departments and work out issues together. We even just recently set up a customer service timeframe on Fridays where the local health departments can call us and make sure that we're there to answer any questions that they have. We're currently working closely with the health officers and our partners to provide, as I said, customer service and well and septic permitting. I think you all know, but we have delegated that authority to local health departments. I think it's working well. Of course, there's always areas in which we can improve, but we've had this relationship with local health departments really since the 80s. And so again, it's not just MDE, it is literally a partnership with the health departments and all of you in this room too. I also work very closely with the Department of Natural Resources, Department of Transportation. All of us have a role in environmental protection and health protection. Again, it's a shared responsibility that we have. We don't work in the silos. This is how we create partnerships, by really making sure that everything we do, we are speaking together as one. Next slide, which is, I believe, the last slide. Okay, I think I've said a lot about, what we do and the relationships that we have with the local health departments, the health agencies, MDOT, DNR, everybody, all the communities. We're here to help. If there's ever anything that I can do to make sure that the relationship we have is even stronger, please let me know. If there are issues that I need to address that you all feel we're not addressing, let me know. We are here to do great things in Maryland, and I'm happy to be here, and I'm happy to answer any questions that you may have.
Great, Secretary. Thank you so much for being here, and thank you for presenting that overview of your important work. The floor is now open to questions from commissioners, so please, if you have a question. Is that? Okay.
Thank you so much for coming. It's always good to just kind of get a refreshing of.
And just introduce yourself and
thank you.
background as well. Just
Sure. I'm Jean Drummond with Healthcare Dynamics International, and just really focused on quality improvements and health equity, population health issues. And so very much thank you for, your department and just the overview that you provided. I did take a peek at that environmental justice link. I already sent it out to my staff and just, I think it's very good. When we think about resilience, when I think about, certainly equity and the environment for different disasters, fire, storms, what have you, what is the ability of the community to bounce back, right? If you've got a little bank account, okay, you go put yourself up in a hotel, you're not waiting for, homeland. And so, my thought is, and I haven't had a chance to look deep into the website, but are there any, so I love the data that you're talking about as well, because that certainly helps with the public health data, but are there any kits or toolkits that you offer that are low literacy, culturally intelligent, that are available? Because I know that would be something that we're used to health departments and just community-based organizations, FQs, that would be able to be disseminated, whether it's electronic or handheld. That's one. So that's one bucket I wanted to ask. Just what are the toolkits that may be available to the communities that would really have that bounce back? Their resilience is not as high. So that's one. The other question was, you mentioned the private dams. So when you say the private dams, are you speaking about a citizen like any of us, or are you speaking about a township that owns it? I'm curious. I guess I hadn't really thought about a private citizen. That's new to me. That would own a dam. Okay.
They don't realize it. That's the problem.
Oh,
Yeah.
Okay.
So you asked two things.
Okay. Yeah.
The first one was about a toolkit, and do we have toolkits available, which I think is wonderful. I don't think we do that are readily available, but I'm so happy you brought that up.
Okay.
I know Brandon is here. We're writing that down. We're going to make sure
Okay.
that we have more information available for communities when it comes to resilience and being ready. We have some, but not a whole lot.
Okay.
And so,
You may not have to start from zero. I think I know of some pieces that could go, because I think to the extent, I'm just huge right now when we think that we've got to support our community. Right? Got to keep them out of the hospital. We got the head model. We have so many things going on, right? And the community is where we live. It's where we want,
and we do want to
build up.
That's
and
right.
So, it may not be whether it's the health department, whether it's, a grocery store, whatever you, especially if we know storms are coming and it's more likely than not. How do we prepare people ahead? How do we share that voice? So,
I'll make sure we do a better job at that, but it is important. We do get information out, but I'm going to look into it just to make sure.
Okay, I'm happy to connect with you.
Okay. Now the EJ tool, you also mentioned that. Thank you for looking at it. It's really good. We also, when we're looking at permits for air and water and all the permits that we have, we look at the EJ screening tool now and see what that score is.
Mhm.
And if it's at a particular number,
Yeah.
then we can do a little more on the permit
Right.
and make sure that they're looking at that particular environment.
Okay,
I've been trying to expand the EJ tool with health information
Yeah.
because I want the EJ tool to be more than just, there's a score, that's a neighborhood.
right.
We need to, asthma is in that particular
Right.
neighborhood.
Right.
A lot of asthma cases, respiratory issues. My vision is to see that tool to be more of a health tool.
Right.
And so we're working on trying to do that. It's
Okay.
been a little,
No, I got
it
it.
hasn't been very easy to get the health information in it the way I would like to have it,
Sure,
but we're working on
sure. Because you could also have the social vulnerability index.
it.
There's
Yes,
the area deprivation
Should have that.
index. There's several other indexes that
yeah,
you can use. I'm just trying to bring resources. We don't have money these days,
yes.
but we have knowledge of where things exist. So you
Yes.
don't have to recreate the wheel. That's excellent.
That's right.
Okay.
And now the last, I'll speak quickly on dams.
Oh, yes, please.
Private citizens is absolutely correct. It's true. Private people have dams. Sometimes, again, what's really is striking for me and for my agency is a lot of times homeowners don't realize that's your dam and they don't know. And so when some of those dams are failing
Uh-huh.
and they have to come up with a lot of money, I'm talking hundreds of thousands of dollars sometimes, and homeowners don't have that kind of money. And so this is why I'm trying to do everything I can to create a fund so that we can help those homeowners, those dam owners.
What does it look like? I've got 5 acres of property and water. I mean, is that what it looks like? Is that what it is?
Yeah,
But I don't know that it's a dam?
yeah, I don't know
Well,
how
water.
it is people buy homes and not know the dam is connected, but it does happen a lot.
Yeah.
And as far as I'm concerned, it's not really fair to the homeowner to know that, yeah, that's your dam. Yeah, something that we're dealing with.
Okay.
So, we do have a question, I think, on the big screen. Mina?
Hi, good afternoon. Thank you so much. I'm sorry I'm not able to be there in person, Secretary, but appreciate you coming to the commission meeting. And also, I just wanted to say, I was very much appreciative when you and your team came down to St. Mary's County to visit with our local folk, and we really appreciated the extra effort you're making to go around the state and visit every local jurisdiction. Thank you for that. I have a few questions, but I'll toggle them based on giving everybody else a chance to ask questions. But the one that's probably the most relevant to the individual work groups of the commission is what types of initiatives are currently ongoing, or how can we move about in strengthening the environmental health workforce for the state of Maryland? And I know there's some initiatives that have been recently launched with our academic partners, but I'd love to hear more thoughts from you as to what's needed to continue on the path of strengthening the environmental health workforce in Maryland.
Strengthening the workforce, the environmental workforce. What exactly are you, when you say
So
strengthening
the environmental health workforce, obviously our local health departments hire environmental health specialists that provide a variety of functions for our individual communities, including those functions delegated from MDE as well as MDH. Many of us face significant challenges with recruitment and retention of this environmental health workforce that affects the efficiency with which our agencies can process things and the customer service that I know you had mentioned several times. And so there's that component, and then there's a component of the environmental health workforce that is employed by MDE and partner entities. So I'm hoping to hear more about, what might be needed as this commission is deliberating on what we can do to strengthen the public health workforce in Maryland, or what kind of recommendations we can make for strengthening the public health workforce in Maryland. do you have any suggestions for what might be needed specifically for the environmental health workforce?
Yeah, I'll think about that. I have heard that there's been shortages in those positions. There's been turnover in those positions. We hear about it because, as you know, if there's a concern or issues that we need to address together, that's when we learn that those positions are not readily available. I think it is an issue, honestly, with pay. I think pay is the real reason, excuse me, why it's kind of hard to recruit in those positions. Those positions in the federal government, they get paid more. And so we do need to figure out, how do we make those positions more appealing in state government? And so that's something that I have spoken with my director, Lee Curry, about. Again, we don't really, because we delegate the authority, we don't really have those issues in particular, but we're concerned with the positions, the issues that you all are having with hiring those folks. So anything that we can do to help you, please let us know. But I have been advocating on your all's behalf in terms of, why is the pay so low? Why is the pay so low? These positions are critical. I mean, really critical positions. So that's the one area that I think we should look into a little more. And I'm happy to help. My agency is very happy to help as well.
Thank you.
Thank you. We'll get back to you as we ask. So next Tosin, and then Camille, I think, is on board. So first Tosin here in the room.
And I'll try to make it quick. I just have 2 questions. So with the attack on DEI, and based on recent shifts in federal policies, where has MDE been financially, like in terms of funding? Has there been any recent change, or have there been recent changes in the last few months or years that would affect MDE's funding? And is there anything new
Regarding DEI?
Yes, DEI, because there's a huge focus on environmental justice.
Yes.
Right. So how does that play into all that is going on now?
Right. So DEI, we kind of separate DEI in terms of, I look at that internally for diversity, equity, and inclusion when we're thinking about the workforce and all that we're doing to make sure we have a diverse workforce within MDE. Environmental justice is more of an external. That's when we're focusing on environmental justice issues and challenges in communities. We haven't really relied a whole lot on federal funding, so it hasn't really impacted us too much because we are able to use state funding. Now, we did have a grant not too long ago from the federal sector for environmental justice. It was quite a bit. I don't know if we're going to get that money. I really don't. One initiative that I had when I first walked in the door, and I've been trying to get it done, and I was just about there, except all these things have just happened with the federal government. But my vision here is to have a small grant program for environmental justice. It's small grants to give to the environmental justice communities. That money is coming from MDE. So I've been looking for ways to bring funding from different sources so that we can start providing grants up to $50,000 to communities so they can do good things in their communities. So that's one area. So I would say in general, to answer your question, no, it has not actually impacted us too much.
Okay. The second question, thank you so much. I think that answers. My second question is around policy.
Yes.
Where, in comparison to other states, I know there was a recent policy around, the program around securing environmental crime fine, right? And in Curtis Bay, addressing biomedical waste, right? So such programs. So where does Maryland stand when you compare Maryland to other states in terms of progressive policies? What is Maryland doing differently?
I mean, if you ask me that, I'm going to say we're more aggressive than any other state. We have challenges in Curtis Bay and Baltimore City and Baltimore County, real serious environmental issues that we have to deal with. And so we are looking at a lot of policy that address those issues. Again, we look at permits a little stronger now. we are very tough on enforcement now. We've increased enforcement by honestly 400% since I started, because we have to do better and we have to address these issues. So yes, we're looking at policy decisions and regulations and things that we can do better to address the environmental concerns. But I would say that Maryland is the leader.
Yeah.
I really do. And I think we have a lot of, some other states have problems, but as far as we're concerned, we want to make sure that Maryland is the leader in taking care of our communities.
Great. We'll go to Camille and then Matt and then Nicole.
Thank you so much. And thank you, Secretary, for your presentation. I had the good fortune to meet your Assistant Secretary for Environmental Justice, Anika Atkinson, last November. I'm Camille Blake-Fowle. I'm the Director of Minority Health and Health Disparities at the Maryland Department of Health. So it was a pleasure to meet Anika and talk about the work that you all are doing around EJ. I know my question relates to your participation as a commission member on the Maryland Commission for Health Equity. And I'd be curious, not to put you on the spot, and certainly we can table this for another time, but as you think about the intersectionality of all of our work, and you definitely, touched on and alluded to the environmental justice and really justice issues that you deal with, both in Baltimore City and across the state. I'm wondering if there are any pressing sort of health and all policies, intersectionality, interdisciplinary considerations that you might surface or want to explore as a commission member, maybe the interrelationship between transportation and the environment or labor. I'm just wondering if there are any thoughts there about how health equity shows up and how, and from in your sort of wheelhouse, how, what are pressing issues that commission can be working on in an interdisciplinary fashion?
Okay, I'm gonna have to think about that. That's a really good loaded question. It's gonna make me think a little more. If you don't mind, let me get back with you.
Oh, absolutely. Well, we're commissioners together, so there's plenty of time to explore that. I just wanted to surface it because I think really we're stronger together, better together, and we have to, as you said, sort of all hands on deck, work collaboratively to make these changes.
Yes, we need to do it together, but I will think about that. I really appreciate you asking that question. So thank you for that.
Thanks.
Great.
Thank you.
Secretary, thank you for being here today, talking to us. One of the questions that comes up with one of my communities is about.
Matt, just identify yourself.
Oh, I'm sorry, Matt Levy. I'm the health officer for Prince George's County.
Oh, nice. That's right.
Is the question that I get from one of our communities in particular is around air quality and in particular black carbon and diesel particulate matter. And I have only limited things I can tell them about what we are doing, what we can do as a county to affect that, because it's, they're on highways and there's state highways and there's lots of different federal regulations and state regulations. What would you advise, or can we maybe work offline to try to figure out a strategy to advise them? And they have lots of, around their community, they have lots of monitors, so they're checking. So it might not be higher than anywhere else, but we don't have other data to compare it to.
Yeah, I think you should definitely give us a call. The Air and Radiation Department, I'm gonna give you the contact name. The director is Chris Holland. We deal with that black carbon and all those issues you're referring to, particularly because of the transportation and all the trucks that are going through Curtis Bay. So we deal with that a lot. And you mentioned air monitoring, having those systems available and up. I think that really does help as well. I won't tell you we have a solution to deal with it that we could just give across the board, because we're still trying to figure out what authority do we have to address those issues. The way we address it is really when it's time for a permit to be renewed. Then we look into it and we're able to be a little more stringent on the permit. But we do monitor, and you're right, in terms of the level, a lot of times they're not under the level. But that doesn't mean it's not a cumulative problem.
Right.
And so that's why we're paying attention to it, trying to make sure that we have a system where we can look at the cumulative impacts. So that's the advice too that you can give your folks. How do you start looking at the cumulative impacts of this kind of pollution? But we can help you with that.
So Chris
Hoagland, Hoagland. And then Brandon, he's special assistant. He can get you that information. Okay.
thank you.
Yes. Thank you.
Great, thanks, Matt. We'll go to Nicole and then we'll finish up with Mina just to stay on our agenda. So Nicole.
Okay, thank you. Thank you for being here, Secretary. I enjoyed your presentation. I'm Nicole Rochester. I'm a physician by training and the owner of a patient advocacy and consulting company. And my question kind of piggybacks on something that Tosin had brought up with regard to DEI and really more broadly kind of the environmental justice screen. I noticed when I went to the website, assuming I'm on the right one, this is a FEMA.gov. When I went to, okay, I just wanted to make sure, because when I Googled environmental justice screening tool, it took me straight to FEMA. There's a specific
Go to
tool for
MDE.
Maryland.
Yeah, it's MDE. It's Maryland's Department of the Environment's environmental justice screening tool.
Okay, that's
Not
great.
FEMA's.
Okay, great. Because the pop-up talks about, the website's being revised, and I know that my healthcare colleagues have lost access to lots of very important resources that were necessary. So I wanted to make sure that there was maybe a plan to move the resources somewhere where they might not be taken down, but it sounds like we have our own state-specific site.
Yes, let
Okay.
me make that clear.
Thank you.
The federal government will never shut down Maryland's environmental justice screen or anything else that we believe in. So no, it's not impacted.
Wonderful. Thank you.
You're welcome.
Great, thank you, Nicole. And Mina, let's conclude with your questions.
Okay, great. Thank you so much. So the one is about emergency preparedness. That is an area that this commission is tasked to consider as we look at the public health infrastructure in the state. And in particular, Homeland Security is on my mind. And I'm really interested in knowing more about MDE's plans or involvement or engagement of local health departments, local emergency operations centers, the state emergency management agency on the topic of water infrastructure and the potential of compromise to water infrastructure in the state, drinking water infrastructure in the state, or contamination of that infrastructure. I'm not sure if that is currently a topic that MDE is addressing in their collaborations with the Maryland Department of Emergency Management.
Thank you. Absolutely. We are involved with water infrastructure risks. I don't know if you're familiar, but about not even a year ago, the US EPA mandated that all states come up with a cybersecurity water infrastructure plan. It was a huge tasking. I came from the White House in particular, and we have a plan to address cybersecurity and water infrastructure systems across Maryland. We also identified a lot of challenges, meaning we don't have people who are trained to actually make sure that we do have a solid cybersecurity water infrastructure system, but we are working on it. Feel free to give me a call later and I can provide you with the plan for Maryland. It is robust. We did work with MDM, which is Maryland's Department of Emergency Management. They looked at our plan, our cybersecurity water infrastructure plan. The health department also chimed in and gave us recommendations. It was a joint effort. So yes, I do recommend that if you could just give us a call, I can make sure that you have that.
Great. And just if you don't mind, Boris, just to follow up on that point, to broaden into a point about communication. And this is something I know that the governance and organizational capabilities work group has talked a bit about, is the alignment and communications within components of the public health system for Maryland, including MDE and local health departments. And, I think there's a lot of interest in, at both state and local levels in strengthening the communication between Maryland Department of Environment and the local health departments throughout the state. So as we were talking about the water infrastructure plan that you introduced, I think that's an example of planning or policy development or process development that could really benefit from the voice of local health departments. And I'm wondering if, I realize we have some mechanisms already established for communication, including those open office hours that our environmental health directors utilize. But I'm wondering if there's another mechanism that could be established to strengthen communications and between MDE and the local health departments that involve the local health officers. So for example, Maryland Department of Health, which is also an agency that we work with at the state as local health departments, has a regular roundtable discussion between leaders of the Maryland Health Department and the health officers from all jurisdictions. And I'm putting out on the table that it might actually, similar type of mechanism might be beneficial to establish to strengthen communication between MDE and local health officers.
Well, thank you for that. I have to tell you, I thought we had that kind of roundtable regular meeting with the local health departments where we're sharing policy issues that are coming about, issues. I thought we had that already. So thank you for bringing that to my attention. I'm very surprised right now. So I will make sure that we create a system where the local departments are a part of what we're doing, and definitely that we're communicating a lot better and including you in it, because it is us.
Yeah. Well, and there is, I don't want to speak as if there's no mechanism of communication, and it's certainly strengthened. I've felt in the past couple of years that there is a environmental health liaison committee, and there are representatives of a couple of the local health departments that participate in those conversations. And I know MDE and MDH converse on a regular basis as well. I was just thinking, how, of course, our job as a commission is to look at how we can make things better. And so that seemed an area that we could probably strengthen with engagement across the local health departments rather than just a couple representatives, and on a regular basis that's intended to inform policy and process. So thank you.
Thank you. I'll make sure we look into that right away. That's important to me.
So Secretary, thank you so much for being here today. And I think this sort of dovetails into several aspects and Mina had touched upon them, right? We're a commission on public health. There's really, no separation between the public's health and environmental health. And the reality is that environmental health has always been thought of as a key component of the public's health, in addition to what we view as the One Health model, right? The concept of what goes on in the animal world, in the world of the environment, i.e. the planetary world, and how it intersects with the world of human health as well. So, and as Mina had mentioned, ultimately our goal of this commission, and we're soon sort of switching into the last aspects of our work between now and the summertime, and by October we'll be issuing a final report to the state legislature and to the governor with exactly that purpose. How do we improve public health at the state of Maryland? And so we would like you to play a partnership role in terms of making sure that we are, in essence, making sure we're bold enough to look at not only what's here now, to look at what's worked in the past or hasn't worked in the past, but to be forward thinking, to be able to design a public health model here that intersects this One Health component that's good for all Maryland. So thank you so much for
I love it. Please count me in.
Great.
I am your partner.
Great. You are, of course, welcome to stay if you like, but I know you are very busy. Thank you for being part of our today.
I'll be in touch to answer
Great.
questions. Thank you.
Thank you. We'll switch gears right into our first big deep dive of the day, and then per our agenda after this, we'll have a short break, and then we'll go into our second deep dive of the day. Dr. Brian Castrucci and Sue Doyle are the co-chairs. I think Brian's going to be presenting here today. We're very excited because, all the work groups play a key role in terms of who we are as a commission and when we're going, where we want us to go. And so I know Brian and many other people were involved in putting this together. So Brian, you're on. Thank you.
Thank you, Boris. So
Let me know when you want to forward this.
absolutely. So I do want to thank Sue, who couldn't be here today, but she has been an absolute fabulous partner as we move through this. Next slide. So I always put this graphic into workforce conversations because we always hear about health outcomes. Right? The HIV rate is down, the flu rate is down, and we seem to think it's some sort of miracle, right? But what we forget is that miracle is on the backs of the public health workforce that never gets mentioned. I conceived of this graphic in the first Trump administration when he was doing his State of the Union, and he was talking about HIV and how the miraculous drugs that we have helped us, really reduce HIV. It's the drugs, the scientists, the pharmaceutical industry. I was like, man, I was in gay bars a long time ago, handing out condoms and doing that kind of work long before there were any medications, but there was no mention of it. There was no mention of the work of the public health workforce. And so I always keep this in here just to center us on what we're talking about. We're talking about the people who protect our safety, our security, and our economic prosperity. And watching what's happening at the federal government, where we are losing our next generation of public health leaders, is very dangerous. It places the entire nation into peril because the public health workforce and health indicators, not health care, health indicators are economic indicators. And so we're gutting our own economy. And so I think, anybody can use this. These are all free to use. They're not proprietary. But we always use that just to keep us focused on where we are. Moving on, next slide. So here are just the framing questions that we had moving forward, and our next slide, our wonderful committee that has worked tirelessly to think through some of the major issues. And I really want to thank Michelle and Bethany and Shamodi, who have been supporting us, especially Michelle and Bethany, who both are resources given by the Dean's office and given by Beaumont to help us kind of wrangle our committee. So next slide, just to go over real quickly our work to date. Moving on to our next slide. These are our activities. I mean, we've met 12 times the work group. We've had drop-in sessions to keep conversation glowing. We've collected input on the PH-WINS instrument, and I'm going to talk more about this later, but PH-WINS is a national instrument to measure the public health workforce. It is the largest survey of state and local health departments, and the one that we just got out of the field was the largest in the history of workforce surveys in public health, with 56,000 respondents. So we'll talk a little bit more about that momentarily. We did meet with the funding work group on overlaps. I think we're going to have to meet with the governance work group. We've heard a fair bit about governance and what our authorities are and how are we allowed to do things. We've had several presentations from folks who, next slide, contributed to some of the health affairs articles on the future of public health. And we've had a MACHO focus group, which I think was really successful. Some of y'all were there. We had 23 of the 24 health commissioners. If you feed them, they will come. So we had a dinner where were we? We were in Anne Arundel?
Yeah.
You were there.
I know. I think it was Anne Arundel. At the Indian restaurant.
Right, the Indian restaurant in Anne Arundel County. But it was really effective, and you got to hear some of the challenges that the local health department is facing. And so if we move to our next slide, some of the themes that really came out of that focus group, including, it was really about HR modernization and review, the pipeline. I think the most important thing, my career was not in Maryland. My career was in other places. I was an epidemiologist in Philadelphia Department of Health, Texas Department of Health, and state WIC and MCH director in the Georgia Department of Health. And, it's really interesting. And where I have been, I recruited nationally, right? I was at big state health departments or big cities. And so I would post and I would recruit across the country. But it was really interesting to hear our local health commissioners here in Maryland say, like, I'm recruiting people who were born in my county, grew up in my county, went to high school in my county, and are getting jobs in my county. So we need pipelines to get those folks into public health. And it's not going to be, well, how do we do a big fancy recruitment to get someone to move to rural Maryland? That may be a challenge that we can't overcome. That might not be the way to do it. We overcome that challenge with pipeline programs. But again, public health challenges around HR, just having flexibility and autonomy. We had a good conversation about taking my belief when I was in practice was if I had three $30,000 a year positions, I might want to make that one $90,000 a year position. I may get more out of it. And the feedback was, gee, we always can't do that. And that was really surprising. So just those kinds of tweaks and hearing, making sure that we have well-documented policies and procedures that are consistent. And so I think that feedback was really very important. Next slide. So let me tell you a little bit about what happened in Maryland with PH Wins. So as I said, PH Wins is a national survey. We've been doing it for 10 years. We recruit states and local health departments. 2024 was our largest survey. It's supported by FIG dollars. We had 48 states and we had 1,200 local health departments participate. Maryland, to my knowledge, is the only state where every single local health department participated. The response rate in Maryland was 55%, which is greater than the national response rate of about 37%. 17 of our 24 local health departments had enough responses that they will receive their own dashboard so they can drill into their data and use this information for policy and planning purposes at the health department level. That's very important. And so we are it's just a plethora of data here. Retention, morale, planning for retirement. Because again, a lot of times when we think about workforce retention and retirement, we know what our retirement eligible age is. And so we can say, okay, this much of our health department is retirement eligible. What WINS gets you is the proportion of your workforce who is intending to leave in the next year. And you might find that the folks who are intending to leave aren't the folks who are retirement age. So what we have going on just in the workforce nationally is a kind of a perfect storm of an early exodus among young people and retirements among our older employees. When those two storms collide, it's going to be a perfect storm. And it's going to be very challenging for our workforce. So what we have is this map of Maryland. These are the 5 regions that we're going to use to analyze the Maryland specific data and produce a commission adjacent report. It's not a commission report per se, but it's a report that we will do in service of the commission at the Beaumont, working with our friends at NACCHO. And we're doing it this way so that no one health department's data is put forward, right? So every region has at least 3 counties in it. So we can say, look, in the National Capital Region, intent to leave is this % versus on the Eastern Shore where it's that %. But no one health department is going to feel like they're under the microscope. And I think this will give us an unprecedented amount of data, just information we've never had. And I look forward to working with the health commissioners and with Boris and with everybody who wants more. Hopefully we'll present it to the state legislature and they can get a whack at it. But this is good data. It's really a phenomenal partnership that really came through working on this commission. So this is why I'm still talking to Boris, because we got this amazing data in Maryland. Next slide. All right, so when it comes to health equity, we're looking at health equity in the workforce, next slide, from the perspective of how representative is the workforce of the communities that it serves. And we're talking about demographics and language spoken and lived experience, right? Do we have the people in the positions that we need in our health department to accurately represent the community served? And we want to think about how do you create more jobs that have lived experience as a requirement, because we've all been in those roles. We've all been in those roles where public health says we want a diverse workforce. We want to have many different people, and you need a master's degree. Okay, guys, that makes no sense what y'all just said. So, if you want to prioritize lived experience, let's do that. Let's have an assistant commissioner who doesn't have the degrees but has the knowledge, right? My argument with health equity has always been, I am a really, really good epidemiologist. And so I bring that epidemiologic skill to any engagement. But I am a straight white guy who grew up not in communities that I serve. So if we can get community input and that lived experience to work with my science, then we get the peanut butter and the chocolate. Then we get a Reese's. And everybody loves the Reese's, unless you're allergic to peanut butter. But we won't be allergic to peanut butter. We'll just say that's the kind of thing that we need, not one or the other, right? And that's, I think, the challenge we've had is a pendulum swing. All the scientists, no, all the community, no, let the pendulum settle for a hot second. Get the best of our scientists with the best of our community leaders, produce the best of the science that we can to lead our workforce forward to help them achieve what they want to achieve, which is better. And next slide. I'm happy to, it's your call. I'm happy to stop and
that'd be fine. Camille?
Thank you for this presentation. And thank you for pausing. I just wanted to surface this notion that they're not mutually exclusive. You can have folks from a community, for example, a Black or brown epidemiologist who fits both, right? And workforce expansion really both recognizes and centers the lived experience, but it's not to say that that our workforce initiative shouldn't be around also finding all of those great, smart scientists who are, of the community or reflective of the community. I don't think it's an either or mutually exclusive. And I just wanted to surface that thought here.
appreciate that. Thank you. Next slide. Go one back.
It's a delay. I don't know why.
Okay, so we've come up with some findings and ideas in these 4 areas: assessing the public health workforce, structural changes, training and development programs, and recruitment and retention. So let's first look at assessing the public health workforce. Next slide. So the concept here is having some sort of commission or group or center that can continue to look at the workforce continuously. I think we all found, Dushanka, you guys did a whole bunch of assessment. We've done a whole bunch of assessment. It's like coming and not having had the background that you needed when you come to your doctor for the first time. Say, well, show me your last 5 years of labs. I've never had labs. Or now moving forward and not getting those data annually. So how do we have a center, a commission that is regularly conducting assessments, providing expert analysis, finding the gaps? It's really something we do often with healthcare. HRSA gives us the medically underserved areas, the health professional shortage areas. We don't really have the same thing when it comes to public health. So how are we keeping a good eye on the workforce and the workforce that we have? So I know we have something in Maryland for the healthcare workforce, but do we have anything for the public health workforce, and how do we achieve that? Going to the next slide, looking at just structural changes that we are thinking about. How do we centralize oversight of local health agencies in an independent office within MDH? How do we empower the local health departments, give them more autonomy, give them a stronger voice? How do we identify and advance strategies to increase autonomy for those local health officers? Create independent human resource systems for the Maryland Department of Health. These have been the ideas that have been coming from our workforce group. MDH is a 10,000 person organization. How do we, or agency, do we need to have a separate HR system for them like transportation does? Michelle and I have been tracking down how that originated in transportation. Finally come to some understanding of how that happened. And again, just making sure that everything that we're doing is well documented and well communicated. Next slide.
Let's go to Mina just for a second.
Okay.
And we'll sort of make sure that we're touching you as we're seeing certain slides and certain ideas. Mina.
Sure. Thank you. And Brian, I really appreciate you presenting on behalf of the workforce work group. I just wanted to provide some clarification based on the conversations I've been in with the workforce work group on the previous slide, the point that you made about centralizing authority. If you wouldn't mind, if somebody could go back to the prior slide, just so I can point it out. Thank you. So this, from my recollection, the work group conversations were not about creating a centralized public health infrastructure in Maryland, but more to increase visibility of local health departments with potentially with a, greater liaisoning, I guess, with MDH. There's certainly some liaisoning established right now with public health services under the Deputy Secretary of Public Health Services at MDH, but that same liaisoning isn't really present with other areas of MDH. And so I think the concept was more to have more, to strengthen that, accountability from MDH to LHDs across the agency and not just limit it to one area of the agency, but not to create a centralized public health system for Maryland.
Right, not centralized, not in that sense. I think what we talked about at the meeting in Anne Arundel was, could there be a local public health office that could bring together the oversight of the local health department so that they could speak more with a more uniform voice, then have better legislative requirements, better advocacy, speaking as one voice, not to have all 24 going in 24 different directions, but how can we get all 24 swimming in the same direction? Does that align?
Yeah,
Mina?
again, just to clarify that it was not to centralize the public health structure in Maryland, the governance structure, I guess.
Next slide. Anytime we think about the workforce, we're going to think about training and development. We need to assess our statewide training resources. What do we have and what are the gaps? And then once we have those gaps identified, we can begin to upskill our workforce. So already in PH Wins, we will have a fair assessment of their workforce training needs. We can begin to look at developing certificate programs that will help us upskill workers in our communities and retain those who are in our health departments, and develop more standardized onboarding programs. We're all coming to a public health system that has some similarities. Everybody has some differences, and you can tailor locally, but there should be a baseline of kind of onboarding that everyone gets to understand the state they're in, how everything works together. As we've been doing this, I'm learning all the acronyms that every state health department throws around, and there's no way to learn them except you stay there for a while and go, what was that acronym? I don't know that one. I now have all my Maryland acronyms, but that will really help us create a more unified workforce. And as people move between health departments, they'll have a better understanding of the statewide system and how each health department fits in. And we want to really create those pathway programs. How do we let someone go from high school to right into the workforce, or from junior college into the workforce? It's not going to always be a workforce that requires an MPH. You might need more training on the job, give people in-place training, because we don't have the luxury in some places to recruit an MPHer. That just may not be possible. I think I'd asked one of the health officers about recruiting epidemiologists in rural Maryland. She said, when I ever get to hire an epidemiologist, I'll let you know how it goes. And so just understanding those differences, that, the folks who are coming out of the schools are probably not maybe going to some of these health departments, we just come up with other ways. Moving on to the next slide. Thinking about recruitment and retention specifically, we want to think about establishing a scholarship program maybe for mid-career professionals in public health, create a Maryland Public Health Corps. Two of the presentations, one came from Minnesota, and one we had a presentation from, definitely from the Rollins School of Public Health. They have a privately funded workforce EpiCore that Woodruff Foundation funds. But you also have workforce cores in Minnesota and New York State. Both have been very successful with big money. And so there's already a kind of a Maryland core program that the governor has started that could be expanded into health. And I do think one of the things we've heard, this is one of the benefits of the Presidential Management Fellowship, is that once you finish those 2 years, you can go right into service, right? It's an immediate transition into federal employment. I think some of the challenges we've heard around internships and fellowships is there's not a clear path. You do wonderfully, and you're a great person. We'd love to keep you. It's really hard to then get through the bureaucracy. But if we created a system where we said, look, you do this program for 2 years, and then we can definitely put you into a position, it may help grow our workforce in our Maryland health departments. We have to create and fund some sort of retention and recruitment fund to better help public health agencies, because right now, if you want to do workforce retention, how are you paying for it? You may not have those kind of flexible funds in your budget. And we need to reevaluate salary schedules to address the high demand positions. If a position is vacant for 6, 12 months, and you need that position, and you're not paying a competitive salary, that may be why it's vacant, because you're not paying a competitive salary. Next slide. So what are we going to continue to do? Go to our next slide. Our next kind of 3 to 6 months, we're going to refine our recommendations. We're going to meet with the governance work group. We want to explore those relationships with different departments within Maryland government. We're going to explore that PH wins data, produce and present a report, hopefully on that PH wins data, brief the legislature, and then do a review of some of the legislative bills, both previously and currently, that have sought to address workforce, like, for example, Senate Bill 971, which had some ideas around some of the ideas we were already planning to recommend. When we think about input that we need, next slide. Guidance on the development of the workforce data analysis to maximize its impact. What are folks interested in to know from the WINS data when we produce that report? And how do we prioritize population health positions versus clinical positions? And this is interesting because yesterday at the workforce, the committee leads, there was this real conversation about clinical positions, right? Nurses, behavioral health, physicians, and that's a part of public health. Don't misunderstand me, but there is a different part of those population level positions that we need, and how do we prioritize them? Because we may not be able to recruit for everything, and we might have to make some really hard decisions as we are facing, cuts within the state and likely federal cuts that may be coming in the future. And so, what are we prioritizing? Is it the population health side of our work, or is it the clinical safety net side of our work? And I think local health departments continue to struggle with this question nationwide. So happy to take any additional questions on that, but hopefully that gives you some ideas of what we've been doing in the workforce group.
Great, thank you so much, Brian. Certainly a lot of work accomplished in what is a complex matter. I think, I appreciate the idea that our work groups are taking the initiative, as many of you have, in terms of making sure that you are cross-fertilizing some of these ideas. As you mentioned, this whole idea of the connectivity between workforce and funding, the connectivity to workforce and what's going on in terms of our governance structures, right? And what's happening in terms of.
So if I could just pick up on that a little bit.
It's your microphone, yeah.
Speaking for the governance work group, we're looking forward to having that dialogue with you, digging in a little bit more. So if you think it, in most simplistic terms, what does governance mean? It means who's in charge, right? Who gets to make the decisions, the big decisions. And with regard to workforce or personnel, you got the state positions and you got county positions. And I don't know, Brian, you probably do. What percentage of Maryland's local public health workforce works for the state versus works for their county? The big jurisdictions have all bailed on the state system, and they have stampeded as soon as they were able into their local government. So it's Baltimore City, Baltimore County, Montgomery County, Prince George's County, Anne Arundel County, I think Frederick, I'm not sure. Anyway, whenever there's an opportunity to get out of the state system, the workforce absolutely wants to go on the local side. So has your group looked at that? Because it's a huge percentage of public health workers in Maryland.
Yeah, I think we've talked about it. I think hopefully in the assessment we've just done and through the NACCHO profile, we'll have a good sense of what that distribution looks like by county. And if we don't have that data, we can go collect that data. But I think we've talked about the multiple different systems that we have in Maryland, right? Some folks have a mix, some have all county, and making workforce policy harder to derive because we actually have, for a small state, we have a lot of different systems. But I do think that's a question. And it was even, as I read Senate Bill 971, that was one of the issues in that Senate bill, was that if you have county health department staff, that you should be able to do whatever you want with that staff. I'm paraphrasing, of course. But I do think that's an important issue to look at, and hopefully something we can discuss when the groups meet together, because you're absolutely right. There is a question of who gets to make the decision.
Right. And so I think it bears investigating what those counties that have moved to those local health departments that have moved to the county system. Why did they do it? Well, because compensation was better and because a lot of the benefits were better and they were held harmless on their pensions. And so if you really want to get into workforce issues, you got to get into the nitty-gritty of pensions and how those operate. And is there interoperability if I go from Prince George's County to Montgomery County? Is it all in the state system? So these are hugely important factors that really will determine the composition of your environmental health people. I'll tell you, those environmental health people, they're so underpaid that they will drive 40 miles to get into a county system rather than to work. So these are some, I think, in terms of governance, it's a really important thing for your work group to take a look at. How is it working in these local jurisdictions where they're paid the same if they work in the school system or the police department or the health department? And that is absolutely not the case in the states, as we know in the states. So,
thank you. Great question.
Great. Other questions? Yes, Matt.
First of all, thank you, but not thank you because I have to follow you. One of the things that we are dealing with, and I know the state does as well, is the role of unions in how we negotiate what the salaries are, what the COLAs are, merits, etc. And I think in order to successfully address workforce, you're going to have to look at what the union role is in doing that. What I find with us, with unions, is that they have the collective bargaining agreements, and once you agree on it, you can't really do much changing. And it's good for the worker, and it's challenging to work sometimes to factor that component in. The other thing I would just throw out there is we're sort of stuck in this PIN process and the salary allocation process where there's no flexibility. So if somebody's in one position, you got to sort of, you can't just sort of move them over real quickly. You got to go up and out or down. And I think that's something to consider as you look at them. I think you all did a very thorough job of trying to address the big issues. I think maybe those two things might be things to look at as well.
One of the things that came up in the work group was the emerging supervisory union and how that would be impacting folks as well. And I think that's still unknown, but it has come up, and it's something we do need to explore. So I think, getting to this point with some of the broad strokes and now tweaking with, okay, how does this work with unions? I feel you. I mean, I walked into my very first health department job in Philadelphia, and someone said, have you read the CBA? And I was like, cohort-based analysis? I'm like, I haven't read that. And they're like, oh, you're toast, kid. I did quickly learn what that was and read it. So again, it's things you don't learn in public health school. Right. How to navigate a union, what a labor management meeting is, how not to cry in the middle of a labor management meeting. But these are, again, this is now how do some of these recommendations hit the, like where the rubber meets the road, right? There are great recommendations written by phenomenally smart commissions, but aren't tested at that local level. And I think we have a fair number of serving local health commissioners on the commission who we'll be leaning on as we refine these to make sure that it makes sense, right? The best recommendation that doesn't make sense in practice is not the best recommendation, though well-intentioned. Yeah.
Thank you for your presentation, Brian. In your encounter with different states through your work,
Yep.
Have you seen any state have a board of public health?
Have a,
Board of, you know how you have like board of.
like a board? Oh, absolutely. Washington State has a board. Oklahoma
Okay, nice.
doesn't do, it's not a gubernatorial appointment. It's a full local board, state board of health.
Mhm, yeah.
Local boards of health, and NABLO does, amazing work. We used to have a profile
Mhm.
of local boards of health, but unfortunately that's kind of, CDC stopped funding it. And so that's kind of gone away, but, the power of a local board of health in a way to depoliticize
Yeah.
some of the politicization we're seeing
Yeah.
is absolutely there. If you look at LA County has a county, board of health,
Of
commission.
public health.
Of public health,
Yes.
absolutely.
Okay.
And so it also helps longevity
Yeah.
in your local health officials, because you have to, if you have a 5-member board, as long as you don't annoy 3 of them at any one time, you're safe. And so the role of boards of health, I think, are important if they're empowered and legislated in the right way.
Okay, I'm gonna reframe my question. I think that was I meant professional board, sorry.
Oh, like
Not-
a,
Yeah, like a
accredited?
board of accrediting, yeah, like a, board of nursing, but like
Yeah,
different,
no.
yeah.
Um,
Clinical, yeah, professional
no,
board, because, you touched on like, the licensing need and,
Yep.
yeah, so like a professional board
Mhm.
that can take on some of that weight. and,
Yep.
Yeah,
no.
okay.
The closest thing we have is the CPH,
Mhm.
which now
Right.
you could do that, right? The state of, I mean, that could be something we talk about.
It's not mandatory, yeah.
Yeah, could you make it a mandatory that you need to have a CPH?
Mhm.
What I will tell you is you would gut your workforce.
Yeah,
Because not enough
right.
people will qualify.
Mhm.
We talked about that when I was in Georgia, requiring a CPH. And my budget director, my deputy, and I was MCH director at the time, we had $500 million of funding. And she said, I would not get a CPH. I don't qualify. But you're not in jail because I'm here. I keep you out of jail. You don't know anything about contracts, Brian. You don't know anything about the state system here in Georgia. You know MCH things, and you do great at your thing. But then you need me to actually make it work in the system. And she said, so why do I need a CPH? So that was fascinating. It was a conversation that's stuck in my head for now, 15 years later.
Yeah.
Accreditation has been discussed. Do we want to, like Ohio, North Carolina, all local health departments are required to be accredited.
Right.
But then it comes into what is the quality of the accreditation? Is it worth the value? Is it, because you're paying for that accreditation?
Yeah.
And is the state paying for that? Does the local have to pay for that? The big push for accreditation came when CDC was allowing a certain funding stream to be used to support those fees. So that's a question, but actually getting to the fact that we don't have any requirement for professional development or licensing
Right, exactly.
is a problem. I could have graduated 100 years with my MPH in Epi and never have taken a continuing education course in those 100 years, and I'm still able to practice.
Yeah.
The CPH was the closest,
Yeah.
but so 56,000 respondents
Yeah.
in WIN, I think it's less than like 5% that
Yeah.
have a CPH. It
Yeah.
just never
Yeah.
caught on.
Mhm.
And for a workforce that is already understaffed and the vacancy rates are substantial, it would be hard, I think, to add a requirement that would make it harder or erect another barrier
Right.
to service. What I think you could do differently is have some of those internal certificate programs. So by 6 months, you must have this certificate. If you are a manager and you've not managed before, you have 12 months to get the Maryland State Supervisory Certificate. And I think that way it's more proactive and then training to the needs in our workforce rather than prohibitive and creating a barrier. Is that fair?
Yeah.
Yeah, I mean, it's a debate over a beer that we can, how do you, I mean, you're asking a great question. How do you professionalize a workforce
Yeah.
in the face of knowing that professionalization, it restricts
The
supply?
training gaps and, how that has come up around. Yeah, thank you.
Yep.
Other questions in the room before we go online here? Okay, hold your questions here. We'll go online. Any questions? Anyone raised hands? Okay, yes, Dushanka.
I just wanted to ask about public health wins and what the timing of the initial report for the commission would be.
We are weighting the Maryland data quickly. My staff is annoyed with me because I'm trying to get them to do it fast. The national dashboards will be out in May. So we're trying to get the data, the Maryland data, weighted and ready to go as quick as possible. So we are starting to build table shelves so that the second the data are ready, we're populating the shelves and we're going to write it. Because we could write the report, a lot of it today and just wait for the numbers to come in and then tweak it. But I think what we really want to know from folks, from academics, from partners, from health departments, what does that report, what do we want it to say? What are we interested in it saying? So that it can be useful and actionable and not just oh, that was a nice report.
I have one more question.
Go on.
Georges Benjamin spoke about the fact that we don't really know what is in the basket of a public health workforce. And your example that you just gave about your supervisor from way back and the expertise needed and the management and efficiency of an operation sitting within a state or local area. So the concept you have put forward as a center for workforce tracking, how do you see that evolve to sort of capture the diversity of what an evolution of what public health workforce needs to be?
Well, I think that's why you have the center, to actually make a centralized place that is asking that research question, right? Where do we who decides to do workforce analysis? It's not something that we get a whole lot of money coming out of NIH for, and any money we would get from maybe CDC. It's very kind of catch as catch can. And when we look at Indiana, you have to look at the wonderful relationship that was there between a funder and the Indiana UIPUI. Yeah, I know, but what's the acronym, Shane? The Indiana University, Purdue University School of Public Health, where Paul Halverson was. I mean, they did, Val Yeager did a phenomenal report. A lot of her data collection was based on wins. We've worked with Val a lot. So I'm trying to do Val's stuff with the data sources that we have. But some of the challenges, we don't have the systems in place. And so a workforce center that's there to monitor would have some of these systems. We are very fortunate in Maryland. We have 24 health departments. We should be able to have a good sense of what's going on in each of the health departments. We should know year by year, what's our ratio by health department to EPIs to community serve? And what does it mean looking at that in Montgomery County versus one of our more rural counties? What should that ratio be? What are we striving for? So when we don't have anything to measure, then we don't have anything to make goals on. And so how many EPIs should we have by health department? Should we mandate 3? I don't know. Why 3? Like, you can play these games all day long, but let's really have an evidence-based, data-informed approach to our public health workforce. The same way you have for the water department or now for healthcare. We monitor how many physicians and nurses we have when we react. But remember, between 2017 and 2021, half of the workforce left their jobs nationwide, and no one seemed to care. And now we're going to lose more. We're updating that statistic as we speak. But if I told you that half of the physicians changed their jobs in a 4-year period, there would be congressional hearings. Person would have more money than they would know what to do with. But we're not having the same reaction when it comes to public health. And I think part of the workforce challenge that we have is we need a value proposition. And that's maybe something to talk with the communications work group about. We're a 140, 150-year-old profession without a value proposition that anyone can articulate. And that's a problem, right? Like, y'all are some of the smartest people in public health. And if I asked y'all to take out a piece of paper and draw public health, y'all wouldn't be able to do it. And if you even did, it'd be different for every person. But if I asked you to draw a hamburger, we all could say, oh yeah, we could do that. If we can't articulate what public health is, if we can't draw public health, we cannot expect lay people and legislators to do what we can't do because we've dedicated our lives to this thing. So I think that's another workforce challenge in a more ephemeral space of like, how do you get the legislature to value this public health workforce and see it as the true foundation of our collective state house, right? None of us really talk a whole lot about the foundations of our house, but when it's cracked, we sure as hell pay a lot of attention. And I think we have to recognize that our public health workforce is cracked and it needs to be patched and it needs to be thought about so that we can get on to the other things that we want to talk about.
Thank you.
Okay, other questions on the big screen? Okay, there being none. Any final words, Brian, in terms of where you want this working group to be heading now?
I think we've had a good group. We've got the data. Now we can start seeing if our data, what the data show us that complement our lived experiences in the workforce.
And I know the working groups have been sort of privy to at least the timeline. We're going to be discussing that shortly as well. Is how do you foresee, and this question will be posed to your working group as well, sort of the next few months of activity, right, for your group? Is this going to overwhelm you? Are you excited about it? Give me a read on how things are progressing and what your thoughts are, or how are you going to handle this stage?
I mean, I think it's already been overwhelming. But I think it's exciting anytime someone wants to pay attention to workforce. And, I think all the work groups kind of sort themselves out at some point of folks who kind of come and listen, folks who have been on the committee but never show up. We have our core group of folks who are always there and always showing up and want to continue to refine these documents. So we're using a lot of Google Docs to, hey, go into this document when you have time, put in your comments, and then coming back in our meetings and refining those and answering those questions. So I think that we'll be able to, I think some of the questions we have around like how many recommendations does the commission want? Because I think you could go on forever and giving us some of those parameters. We want your top 3. We want your top 4. That would give us a whole lot of guidance as to how to drive this because again, 3 systems, 24 health departments, years of pent up, no one's asked me, are all getting played out right now.
Right.
And giving a little more definitiveness. If you list 97 things, you're going to get 9. But give us your top 2. But then have a set of things that we could just do, right? Because that's the other question, right, Boris, is are we talking just about legislative recommendations or just the stuff we should be doing that we could all do with a nickel and some friends?
And I think that question will be answered with time from the commission and where we're going to be going. But the answer thus far, from my perspective, is yes. Right? It's not just legislation. It's in essence is this report, we're projecting ourselves, right? Draft final report by June, July, right? With the idea that we then open that up to the public, including, right, the working groups who then can further opine on this and help us, be architects of what then is issued in October that provides, in my view, a direction both for the state legislature, for the governor, but also just for public health leaders to say, this is where we should be heading. Right? I still remain enthusiastic as one of the 3 co-chairs here, is that at the end of this, we are going to have a stellar document that points a pathway. We aren't responsible at the end of all this for full implementation of this, but we have to be able to point towards, hey, these are great ideas that we have. Here are recommendations, and at least think through who should be the implementers at some point. And perhaps they're generic implementers. Perhaps it's public health leadership. Perhaps it's academics working with the public health leadership and the community and all that. So it should not necessarily be, we shouldn't think of this as a sole, we're pointing the finger at you, but it's the community, right? That's what we're trying to instill.
And don't neglect the Maryland philanthropic community and the company programs
Right.
that are, because you would say, especially things that are time limited, like build this training.
Yeah.
That's something you can, as a philanthropy, you'll fund that all day.
Yeah.
Right? It's done. It's discernible. I have it. It works. It's the things that go on forever, right? Fund this home visiting program. It's very hard to sell because at some point I know I'm going to stop funding it and it's going to go away. So that's that delineation of a set of things that we can do that take a one-time investment and we can be done and then reap the benefits, so a higher ROI, versus the things that are going to require funding forever. And I will guarantee you that every philanthropy will stop funding that program at some point.
And I just want to have something to I'd spoken to Brian about this earlier before the meeting, and I just wanted to be reflected in the minutes, is that Brian is by far the most dapper dressed individual, not individual, I won't say it, man in the room. And so anyhow, thank you, Brian, for blessing us with your presence here and for your and Sue's incredible work in terms of this committee. We are now
really quick. To answer Brian's question, because it does impact all of the work groups and how we're talking about recommendations. I want to be very explicit that we are not limiting ourselves to solely legislative items. If there's something that needs to be addressed relative to the work of your work group and that domain, and it's an administrative policy, a rule, or something in between, that is on the table, absolutely. So please don't limit yourself artificially on that account.
Great. Let us take a few-minute break until the hour of 10 before 4. So we have like 4 minutes to break. Restrooms are outside here. And then we will go to our mission updates. And following that will be the deep dive from the data and IT work groups. So I think it's been rather successful that we do have a good number of people here in the room, but we also have, just for everybody's note, 33 people online. And so this commission meeting remains something that's quite of interest to many others, not just the commissioners and work group members, but others as well. So thank you all for being here. Once again, I'll mention just from a housekeeping perspective that really what we're this is a meeting of the commission, and specifically to any members from the public or others who are on. If you do have any comments, please send them along. We aren't monitoring the chat, but email is md as in Maryland.coph as in Commission on Public Health at Maryland.gov. And so we're eager to hear any comments you may have based upon what was discussed today. We are entering the last half of our meeting here today. And it's actually shorter than the last half. And we're going to start off with, for the next few minutes, it's going to be commission updates. I'm going to hit you first with general updates and then switch over to Shane. In general, I do want to mention that, we did during the roll call mention that Benjamin Chen is on as a representative from as a designee from the Deputy Secretary for Behavioral Health, and we welcome Benjamin to this group. Alyssa Lord has designated him as her designee at this point, and so that provides this the impact of behavioral health and having that input here. So we welcome Benjamin to the group. I'll also mention that at the last meeting, in terms of updates from the commission, is there was a motion that passed that talked about empowering the co-chairs to write a letter of support to from the Maryland Commission on Public Health for the AHEAD model implementation, the Population Health Improvement Fund. This was mentioned as House Bill 1104. And with the blessings of the commission of taking on some of the subject matters, and I thank Fran and Chris and Dushyant for assisting us in terms of getting a letter out. A letter was sent on February 7th to the legislature, and then we received a reply from Delegate Pena Melnick thanking us on the 10th of February for our advocacy on this. So I think this is a key component of us being able to react as we did in short order. As you all know, we are in the midst of the legislative season here in Maryland, so there's a lot going on. It also explains why some of our legislators are not able to fully attend our meetings at this stage, but we're eager to see what goes on in the legislature. I also want to mention from our mission perspective is that don't forget that as we issue a final report by October, the supposition at that point is that that becomes then part of the formula for the next legislative season. And so initially when this commission was set up, as you know, we started kind of late. By the time we were all put into our positions, things were rather slow at the beginning. We've caught up to speed. We are a year behind because the supposition was that we would actually have that work for this legislative process. This legislative season. So, but let's get eager and interested. As mentioned when Brian was here in the discussion, it's not just about legislative approaches to the Commission on Public Health, but we see that we will play a role in the next legislative season in terms of our recommendations being utilized to put forth matters and hopefully to get some traction. I'll also mention the fact that from our timeline, even though we're issuing a final report by October, this Commission on Public Health does not sunset until June of 2026 at this point, which then puts us into the mode of perhaps not holding regular commission meetings. We'll see what we're doing at that point in time once the report is issued. But certainly we're going to be relying to a large extent on our commissioners to be those advocates or sources of information as, for example, partners and members of the legislature or the governor's office comes back at us and say, can you explain this or can you help us on this, right? So don't forget that certainly from the commissioner's perspective, things will change in terms of our tempo. But to a large extent, we don't sunset as a commission until June of 2026. I'll now pass the microphone over to Shane, who's going to brief us on other activities. Shane, if you will.
Thank you, Boris. All right, so this eye chart for the people in the room is our regular update of the timeline. Really not many changes from what was shared last time, as well as what was sent out to you via email. At this point, wanting to highlight a couple things. One, I'll note that picking up on what Boris said, the full timeline, not just this snapshot here, does contemplate that there are post-October 2025 activities and essentially a role for folks to play in that as we kind of determine what makes the most sense and what the ask ends up being. So we've not lost sight of that even in how we're kind of structuring the way we talk about the work ahead of us. Next month, we will have our academic assessment team back to chat with us about their preliminary findings, which again, Boris noted, folks heard at our leadership meeting yesterday, kind of that first draft of what those were, so that can start to be included in the recommendations development for the work groups. And so the full commission will get that preview next month. We're planning on devoting most, if not all, of the meeting to that point, as well as finalizing the mission, vision, and value statements, which I'll have a little bit of a note about here in a few moments. So overall, we're really at a point where things are pivoting towards this rubber meeting the road, creating these recommendations, putting up loose ends with respect to our analysis and assessment piece, both at the work group level as well as the full commission level. But it is really, I think, starting to be in the home stretch. I guess being from Indiana, this would be a turn 4 moment, thinking of the Indy 500 race. Next slide. This is a walkthrough of where we are starting to work with the work group co-chairs on thinking through what the next several months look like in particular. We planned this out as a draft for discussion all the way through essentially October of next year, or excuse me, this year, but really want to focus on the next several months in particular. Again, as we are making that pivot towards the crafting of recommendations and getting together some of the narrative for the report, which we're talking about strategies and ways to do that. So at this point, we're putting together templates to facilitate collection of that information, wanting that to be more along the lines of updates to what has been submitted already, so that work groups aren't feeling like they have to craft a bunch of narrative themselves. We will be bringing on a technical writer to facilitate that again, like we did with the interim report. But again, what comes out of that process is a function of what is given to the writer. So please do think about the level of information and detail that's being provided, so that this individual is able to kind of extrapolate from that and then pull that together in a cogent, cohesive voice. The other piece that I wanted to highlight here is noting that based on one of our earlier conversations about this rolling recommendations timeline, having a sense of what those kind of checkpoints were for getting them in to be considered at particular commission meetings. Verbally, we mentioned about a week before the regular commission meeting is what we were looking for. And now that we have those dates, for those additional commission meetings, we're able to provide those kind of goalposts in terms of getting recommendations in. So our first one that we'll encounter is approximately March 6th. So for the work groups that are continuing to meet yet in the next couple weeks, that'll be an opportunity for you to get any initial recommendations in for consideration at that next meeting. The following one will be March 31st for the April 3rd meeting, April 8th for the April 15th meeting, April 24th for the May 1st meeting, and then May 13th for the May 20th meeting. Next slide. So going back to the video and listening to some of the conversation we had, as well as my notes from just the very quick conversation here in January, I made a couple edits to these statements that are certainly still something that you can weigh in on, and we're not going to really have enough time to talk through all this today, and we don't want to rush this since it is so important and formative to what we are doing. But I wanted to at least get this read into the record and give you an opportunity to reflect on that. So here in the vision to one of the comments we heard about having measurable improvement, added in this idea of improved health outcomes to try and get to that. Again, the language may not be perfect, but I do welcome offline feedback to how we might be able to address that. Next slide. And on this slide, I made adjustments to the communication and innovation value, again, based on some of the feedback that I heard in the room, particularly around noting where we are with our federal partners at the moment, that we need to be very thoughtful about being that scientific voice of reason. So that's noted in the innovation value. And again, a restatement of that achieve improved outcomes idea, making sure that we have measurable improvements, that we're not just doing activity for the sake of it. And then also noted the data informed communication, with that really being something that is certainly in need at this point in time. So if there are things that are missing from there still, or tweaks that you feel are warranted, please do reach out. But essentially, that's where we are on those pieces. And I believe that completes me.
Great, thank you so much. And getting back to, sort of the process on mission and vision, really do look at it, all commissioners, please, and get us your feedback. What we'd like to do is at some point put in a motion to accept that. People will oftentimes criticize us saying, well, you should have done the mission and vision initially. And I know we've been sort of in evolution. The reason we're sort of pushing it at this point is that's going to be sort of the path forward, I think, at the beginning of our final report. So it's kind of, maybe backwards to some extent. It probably would have been modified. But what I'd like us to do as a commission ultimately is to ratify what is going to be in our final report as we sort of saw the process go on over these last few months in particular. So thank you so much, Shane, for that. We're really excited to have Dr. Matt Levy and to have Mr. Craig Bem here with us. This is really important to us, as is every single. So, people oftentimes ask me, like twice a day, Shane, I get this done. What's your favorite work group that's out there? And, it's like having, I can't select one. It's like I have two daughters. Who's my favorite daughter? I can never answer that question, right? I'll tell them aside, when I have my older daughter, Larissa, you're my favorite. But that's only amongst this part, right? Exactly. And then I'll tell Stephanie, you're my favorite. So the reality is that every group here is important and is critical to our mission. But also the group that comes last has been waiting the longest, right? And this is our last deep dive, right? So I do welcome Matt and Craig here to discuss with us the data information technology work group work to date and some of your findings, and let's have a great discussion after this. So Matt, I think you're starting, is that correct?
Correct.
Okay.
I just noticed that the first screen is different than what I have in front of me. That's okay.
Good sign.
Yeah, I don't know if it's a good sign. Well, we tried to stick closer to the themes idea and not get into the recommendations yet, but we were just talking about it, and we are very excited about actually getting into the recommendations, because I think we can really drive, hopefully this will really drive change, and we're very excited about it. So this came from one of our members. Public health is a data-driven profession, and accurate, timely data is the foundation of what we do. And really I probably could just stop there, because that's really what we're all about. And if you're looking at like quality improvement science, you have to know where you started in order to know where you end up. And our data systems are very much evolving, but are not close to a point where we need that we can pull data and look at it quickly and make a decision. So we really try to focus, next slide please, on the areas that were brought up for us to focus on, which is characterize assessment and surveillance systems capabilities and limitations, make recommendations on cybersecurity, protection of data, system integration, artificial intelligence, and maintenance. And we're going to expand on those in the recommendations. Assess systems capability of local health departments, make recommendations to improve systems, especially centralized administrative systems and software. And what does that mean? And what does that look like? Something should be centralized, something should be put to periphery. And then identify procurement and contractor oversights, challenges as pertains to systems and projects. And really, we often put the data, the business side of what we do aside, and we think about the public health and patient side of things. We need to have a fusion of both of those in order to be successful. Next slide. So I want to, thank my colleague here, Craig, that was with me and agreed to take on the role of co-chair. I do want to give a shout out to Jay Tende, who really worked with us for a whole year on trying to move this forward. And I do want to put out a shout out to Sarah Bora and Megan Rooney, who have been driving the train. We're just sort of passengers on it and kind of turn left, turn right, but they've been really driving the whole thing forward. This work group is tremendous. Most of them have some, if not all of them, have background in health IT and information systems, and we're really very fortunate to have such a great group of thinkers and giving us, we've had very rich discussions over the course of the last year. Next slide. So our work to date, we have had monthly meetings. We initially started with the idea we should have a vision and mission. And we really spent a little bit of time trying to put that together. And then we said, you know what, maybe we should just stick to the goals for now and really focus more on the goals of what we're trying to achieve, and also and expand on those. So we spent some time on those. And then in the course of things, we started to move towards putting together the assessment questions. And we really put together a subgroup to put together those questions and bring it back to the larger group. In the middle of that, some of us went to the NACHO 360 conference and got even more ideas around how you can use public health data, how you can use AI as a platform. And we're just barely scratching the surface. I'll get more into that in a minute. Next slide. So our work group goals were to integrate and organize public health data across health and human services. We wanted to include human services in this because it's really, the social determinants of health are really a critical element of what we do in public health. Entities at the state and local level ensure access to actionable data, which is keyword is actionable data, tools, resources that drive evidence-based policies, cutting-edge research, and coordination of care across involved entities. Maintain the highest level of privacy protections through data security and streamlined consents. Accelerate automation to create efficiencies in data capture, analysis, and use the population health lens / health equity lens in data collection, data analysis, data interpretation, and really data presentation to populations and to different organizations and different folks that can use the data or need it to make good medical decisions and health decisions. Next slide. So we had several experts come and speak with us. We had Dr. Brian Dixon, who is the Director of Public Health Informatics at the Reigenstreif Institute and Indiana University. And he really came and spoke with us about data monetization and using health information to exchanges and governance. It was really a wonderful speaker. And then before that, Christina Gray spoke about the sort of the local health departments and the challenges, opportunities, and barriers that that we face looking at data, what kind of things we need to do in order to have the state and the local communicate with each other more effectively. And then Craig came and spoke about the wonderful work that CRISP is doing and where it's headed. We still have two more speak. We actually had a speaker from CDC, John Cusick, who was supposed to speak at our last conference, and they went silent. So we didn't get him to speak, but we have some of his slides and his information. And then hopefully in the next month or so when we meet, we're going to have two speakers. We've invited Marcia Perlowitz, who's on the call today, to speak, as well as our own HR manager, Manti Murray, who is incredibly gifted in understanding how to create enterprise architecture and design. And so we're going to hopefully get the state approach and a local approach that we could fuse into the recommendations as we move forward. We did a resource evaluation. Our intern Miriam conducted a literature review. We looked at some of the Oregon, I think we looked at Indiana and Minnesota to get some more information. So next slide, please. The health equity and cross-cutting themes. The next slide. Data representation for us is also really health equity. And our goal is to ensure that there's full coverage and accurate representation in our data collection, data analysis, and data interpretation and data presentation. The collecting the data in a way that helps differentiate differences in people and regions so that we can look at disparities, truly look at disparities, and understand the formats in which then data needs to be shared and the barriers and limitations to understanding and sharing and interpreting that data. So we really try to look very closely at what that would look like. Next slide. We also try to connect it a little bit to the head model and the flexibility for CMS to share more data with Maryland. And we're just scratching the surface of what that really means. But we wanted to make sure we put a kind of a note in the file here. Next slide. So I'm going to go over two of the initial findings, and then I'm going to pass it to Craig to take us home. So we found 5. We had more than this, and we realized that a lot of them overlap, so we kind of consolidated them into 5 big areas, 5 big buckets: data barriers, EHR systems, coordination, modernization needs, and workforce. So next slide. So as we said at the very beginning, data is really the heart and soul of why we have all these systems connected in the first place, so that we can use that information to make health decisions to support populations. The theme here is that there's a lack of accurate, accessible data and efficient data capture that is crucial for informing public health policies, surveillance, managing outbreaks, I'm losing my voice, and improving community health outcomes. And really, that's sort of the centerpiece of the data. There's plenty of barriers. Data availability is a big one. Data use agreements. Every time we want to do something new, we have to sign a data use agreement. It has to go through lawyers, it has to pass through different hands, and it's very limited. And we have to look at that from a more global perspective. Out-of-date technology and interoperability standards. So definitions are not the same. So you might look at one definition in an EMR might be, the use of asthma in 6 months, and one might be asthma in a year. And you can't compare those in one setting, so you have to adjust them to make sure that they are equal. If we have a way to create some more interoperability standards, then we can actually look at apples to apples. There's also difficulty in obtaining qualitative data rather than quantitative data. Data transparency is a big issue. The outputs we require, they require significant expertise to interpret. And there's little consistent communication with the general public in a usable, equitable format. Now, I have to give Maryland Department of Health kudos because they really are trying to create these dashboards that people can then use that are easy to use and understand. And I really think that is a step, a very positive step in the right direction. There's critical data points that are missing, and incomplete, inconsistent. And again, back to those definitions, we have to make sure that we are on the same page no matter where we're pulling the data from. All right, I'll go one more. And then I'm probably not gonna be able to speak. EHR systems. This is also the tool that we use for the data in the health departments. It's not the only tool we use. We have plenty of other tools we need. This is a big one. There's a level of variability and consistency of the EHR systems implemented across the state. We have Epic, other places have PatTrack, CureMed, Patagonia, just to name a few. And that creates really an inability for us to communicate. So if St. Mary's County wants to do something with us, we can't really communicate effectively. Excuse me. And then, so cost is a big issue. We don't have any, first of all, we don't have any bulk purchasing discounts. We don't have opportunities for shared investment and training. Systems are also specialized. EHR systems are generally written for healthcare systems. They're not written for public health systems. And the things that we do are different. For example, environmental health tracking. Now, environmental health is even more specialized because you have the permit, you have the collection of the fee for the permitting, you have people looking for their permit from one side and us looking at the permit for the other side. And then you have, once the permit is issued and you're tracking things, you can't track effectively. So restaurants and pools and septic systems, there's no really good way to track that. And then if you're trying to track a disease and you know, doing an epidemiologic analysis of a disease, looking for where it started, we don't have any clear way to do that. I know the state used Salesforce during the pandemic, but I think that has not been continued. Interoperability, we talked about that. And then the last is reduced rapid adaptability to new public health needs. So something happens really quickly that we need to act on. We don't have a system that is flexible and malleable to be able to adjust to that. Now, is there a system out there that can do that? We don't know yet. But if not, maybe we look into what it will look like if we, you know, if we do it ourselves. I'm not gonna say that out loud. Did I say that out loud? I didn't say that out loud. So I'm gonna pass the mic over to Craig, and he's gonna take us home.
So ironically, we're going to switch to the less technical portions of the technical. So what Matt presented in my mind is kind of the data barriers, right? There's the issue of the data we have is not necessarily great data, right? It might not be linked, it might not be full coverage. And so that's a huge challenge. The second half that he was referring to is also like using the data, you know, these kind of siloed data sets, you know, a claims-based report might be really helpful for some things. It doesn't tell you about anybody who's never been to any provider because they didn't get billed for services. And so you have lack in kind of the collection and the usability. The next set of findings, so coordination is maybe the good theme to start with. We found that even if you have some clear data, we all want better air quality in Prince George's County. It's really hard to coordinate any of the efforts across the agencies or the actors. A lot of that is IT driven because you don't have you know, a single set of kind of evidence to base your interventions off of or test your efficacy. Certainly privacy laws, HIPAA, and then FERPA came up a lot in our conversations. Even if the data is in existence, it's not necessarily linkable for the purposes of coordination. And then quite frankly, people are just really busy. So for example, CRISP does a lot of support for public health dashboards and for different state-based models. I've never heard of the environmental justice screening tool. And it sure seems like all the data I have would be super helpful with all the data that.
Exactly what I was thinking.
Yes.
Secretary should have talked to you and
Never
not us.
close. Never close. And it's probably because the health secretary's doing a lot of work in health and the environment secretary's doing a lot of work in the environment, and it just doesn't link up. And I think we see that kind of at every level. Which is not a public health problem, it's not a health IT problem, it's like a humanity problem, but it's certainly a barrier. The next one, modernization. So part of this is like the term of art in terms of the data modernization initiatives. There has been a lot of funding that's flowing in, particularly from the feds, to push kind of this rapidly changing IT system. That's really great. It also, though, we found is insufficiently resourced to kind of keep pace with these kinds of innovations, right? It was great to have a shot in the arm, but there's only going to be more as we consider AI and kind of how these gaps in future states widen. If you invest in your ELR system, you didn't invest in your ECR system. You invested in your environmental health systems. You didn't invest in your school-based immunization systems. And so kind of keeping just up with this treadmill is very, very difficult. The barriers there, cost is the very obvious one. I mean, certainly there's upfront, but also just ongoing maintenance for systems is very significant. And we wanted to sprinkle, we weren't quite sure how to include AI formally in any of these, but essentially, and Matt can correct me if I'm wrong, I think essentially we decided modernization is going to be aligned with and hopefully supported by artificial intelligence. But we don't have regulatory framework. We don't know the value propositions. We don't have thoughtful use cases. We don't know what responsible implementation even looks like. So there's this thing we know we want to use, but we have no clue how to even think about using it, which is going to be a very expensive modernization process, even just in kind of time, community input, like just the ethics around it. And then the last one, number 5, more or less the last one. So workforce, you already heard this a lot from Brian. Someone's here. It's the AI coming again. So there's all the same challenges in workforce that exist in the health workforce, which then is twice as hard in the public health workforce, is also hard in the public health IT workforce. It's a very competitive industry within a very competitive industry. So we wanted to highlight the competition, and then also training. It's hard enough to get the best people to keep them trained up to date. But then to Matt's earlier point, if you have 15 EHR systems across 24 jurisdictions, plus all, some people are coding in SAS and some are using, different database types, languages. It's really hard to train and maintain a workforce when also the tools are not consistent. You can't train at scale, and you can't have these services at scale. So we're kind of cutting ourselves both ways. Let's go to the last of the findings. The group, there's no shortage of barriers and themes to throw out. We had kind of 5 broad ones, but this is a sample of others that we thought had to be highlighted, but also we could probably have 100 on the slide. Just digitization. It's really nice to have, in 2025 moving forward, to have all the data in a really nice data lake and be able to use it, but we don't have last year's data, right? So at some point, in order to do anything longitudinally and all the issues that you'll deal with, which are generational, having data going forward is not nearly as valuable as also going backwards. Inconsistent use of business technology. Now, this touches a little bit on the workforce concept, but the business of running your health departments is a difficult business, right? Some of you bill for health services, some of you don't. You have different state and federal grant opportunities. I'm sure you're working cross jurisdictional within your counties. The same you are on the workforce side. You have unions. Some of you have your own employees at the county, some of the state, and so that just makes it really hard to have the flexibility and to kind of like respond quickly as a business. And then finally, there's like lack of central repository. This concept that we have, all these individual jurisdictions is, I don't know enough about it to be supportive or critical. I think healthcare is local, public health has to be local. But it's hard to see the efficiencies gained if they were more uniform versus the value of being flexible and hyper local. And I think our group, as we think about recommendations, is going to struggle with what's the appropriate balance. So with that, let's go to the next slide. We're really kind of into next steps on our side. I'm not going to read all these questions, but it was very clear from the findings that we're going to have a bunch of questions that we need to review in order to figure out what our recommendations will be. So for example, we kind of in a vacuum might think, wow, a single EHR run by the state, leveraged by all the jurisdictions, seems like a really efficient way to do things. I don't actually know if that's true. Like, I know it maybe sounds good on paper. I'm sure there's a reason why you don't have a single EHR. And there's probably a lot of kind of push and pull of various factions and value props. So we're going to have to wrestle with each of those issues. Saying centralizing data is really nice to be out of a single data lake. It's also a single point of attack, single point of failure. There are pros and cons to all of these. So I anticipate that's really what we're going to be wrestling with in our next few meetings.
And I would just add that we don't know, we talk about AI, but we really don't know what other next generation technology is going to come up. We can't predict it either. And that's going to, you're going to have to be nimble enough to be able to adapt and move forward with something new that we might not have thought of to be able to make this most effective. And is the network, is it better to your point, is it better to be decentralized or centralized with most of your work, or it's probably a combination of the two? Whatever makes most sense to be centralized, try to centralize it. Whatever makes most sense to be decentralized, then you do it that way. But it has to be part of the same whole. Otherwise, you're just spinning your wheels.
So we do have one more slide. It's really kind of the final next steps for us. It's really kind of homing in on these recommendations. I think we'll want the same guidance that Brian asked for. We're happy to do. I think we'll have a very comprehensive pie in the sky. If dollars and time don't matter, what will we recommend? At some point, dollars and time do matter, so we'll have to prioritize and think through. Kind of final recommendations across different policy levers versus pie in the sky.
And I think we're open for
Great. Well, thank you again for that. There's a lot of moving targets there, aren't there? Right? And I think this is certainly part of the excitement of where we're going. Let me ask the first question, because I want to sort of be on the cusp of what you had talked about, which is being nimble and being unable to predict the future when it comes to things like AI. And we've seen this incredible metamorphosis in our own lives, the academic world, the world around us. And we're always kind of behind on things. My question really to you is, and it's more of a plea, is that ultimately when you begin discussing sort of pathways ahead / recommendations, is that we need to be able to at least acknowledge the fact that, AI is upon us. And what we considered about, data and the IT work group is that, it's not just, a generation ago, we would have talked about, well, we have to get bigger floppy disks, right? That hold more information, right? And now when I mention that, all you hear is laughter, and the younger people probably have no idea what I'm talking about. If we have, those, right? What am I talking about? The question really is to be nimble is what's the recommendation ultimately? I'm not asking for a response other than the plea to you is who's going to keep tabs on what public health needs to be looking at, right? Who's out there? Is it something within the Maryland Department of Health? Is, I would like to have somebody out there working with, sort of the bigger vision of saying, okay, here's what we should be latching onto right now. We should get rid of the floppy disks and we need to pursue something, right? So any reflection on that from your working group?
I mean, we started to sort of talk about mostly AI for the future, and it was sort of present future and what role AI could play. But as far as I guess it comes back to the centralized or decentralized. Who's in the best position to assess new technologies, and do you create a whole new group that their whole job is to test that technology in a safe space so it doesn't get out, so to speak, and try new things and say this would work and then run it through. And I do think that Maryland Department of Health is doing that. We just don't see it as readily available, I think. The other place that often does this is CDC. Now they're not really helping at the moment, but they do a lot of innovative ideas and thinking about next generation of whatever it is.
Yeah, my only two quick response, I think one is like the time to market is still long, right? So you had the US Digital Service, which is now gone, working with the CDC, which is half gone, to deploy kind of open source technology and all sorts of things. I'm not sure any state or local health agencies were tooled or resourced to take that stuff and implement it. And so you're kind of working on like second or third generation tech because we finally got the grant to move NBS into the cloud, right? And that's not forward facing, that's just cleaning up because it takes a long time to do things. And depending on how big an idea we want, I almost think of like, should the Bloomberg School of Public Health have an innovation hub, right? Where all they're doing is just always trying to think in the future.
Yes.
So all we need is $1 billion but I do think like that.
I mean, Bloomberg's name is on the building, so
it's around me there. But we'll, Forrest, to your point, we'll take that guidance to think big.
Going on to the screen, I think Mina, do you have something?
Yeah, fantastic overview. Really appreciate the thought that went behind the presentation. Thank you to you both and to all the members of the work group. I had a few thoughts if I could share. One is this concept of more of an enterprise approach. I think because of under-resourcing, under technology, under staffing and staffing expertise, gap in staffing expertise. I mean, local health departments have really fallen upon this. Let me deal with kind of the technical support of our data systems. And they're not, and some of this is a product of the categorical funding for public health, is that we're not really thinking about technology across an enterprise and how technology can be leveraged to handle, like themes of work versus, we need this data system for the cancer registry. We need this data system for this, categorical area and so forth. And so we end up with the dozens, if not hundreds of systems that we currently have, as we have heard about and talked about in previous commission meetings. So I think, my comment is one about, how do we work to transition health departments, particularly local health departments, into more of an enterprise model of implementing technology. And then two, it's not just about getting the grant that allows us to buy the system or the technology. It's also about having the ongoing expertise for implementation of that technology in a way that makes sense for the needs of the agency. And then really, we need to be better about decommissioning technology that is no longer relevant, advanceable, or no longer is meeting the needs of modern day public health. And I feel like government in particular, we can do a decent job of acquiring or even building with our consultants and so forth, technology. And, I don't believe we do a great job at implementing, but that is an area that we can build. I feel like we generally in government, we do a poor job at decommissioning old technology in order to pave way for better and more modern technology that meets our current day needs. So again, like as we think about workforce and resources that are needed to advance public health technology so that we're serving modern day public health capabilities, keeping in mind the role of decommissioning, the role of implementation, and kind of the enterprise approach to technology. So that was my first kind of comment, and that I really appreciate the expertise that's around the table for the data work group, and hopefully those will be considerations as you look at recommendations. And I think, to speak to Craig's point about innovation, which is also incredibly important, is how do we build a culture of innovation in a work setting and in an agency, and connect technology to that. So I think that enterprise type of approach might help with innovation and triggering innovation. The other, the other comment I had was about the topic brought up about consolidating systems, and the topic you brought up about centralization versus decentralization. Exceptionally important to explore, because you're right. We have been talking quite a bit about having one statewide EHR that satisfies all the needs of public health at local levels and state levels and so forth. And wouldn't that be grand? And perhaps it would be, but there's also, as Craig was mentioning and referencing, there's a lot of concerns then about you have a single point of failure with a particular vendor, as we've seen in previous arrangements with particular vendors and so forth. And then it's also from a cybersecurity perspective, is that really the safest way to approach housing our data or serving our data needs? So, but appreciate the chance to comment upon it. I really am thankful for all the work and thought that went into this. And if there is an interest in building a center of excellence for public health informatics in the state, I think you all would be wonderful additions to that.
Mina, thank you. And I have some ideas and I'll fax them to you.
Good one.
Well done, Matt. Well done.
Any reflections on what Mina said?
I mean, she's spot on, and the enterprise architecture has to be the whole, right? The entire state, and which pieces live where, which people live locally in the state. We're not going to find, I don't believe, one system that has all the bells and whistles, unless we build it. And I don't recommend that. I'm not a big fan of. I'm going to counter what I said before. I'm not a big fan of homegrown systems, because I think they don't have the support to be able to upgrade quickly and add security layers over and over. You have to have something that has enough, a group or a system has enough bandwidth to be able to do that effectively. But I am a fan of having as few systems as possible to do the work that we need effectively, because if you have 15 systems, to what you said earlier, you gotta upgrade 15 systems every time, and that means you have to have a very big team. And if you have 15 systems centrally, that's all do something slightly different, then you keep having to work on those, and that's just at the maybe one level at the state level. So I think the less we can get away with to get what we need done, the better, in my opinion. And I agree, decommissioning your relevant technology. We're always afraid to throw away that first cell phone we had. You know, even though it's sitting in the drawer it's been sitting in the drawer for 10 years. I think I still have my Palm Pilot from 25 years ago. So
I was thinking the same thing on decommissioning, and healthcare seems to have like these like whisper like issues of someone thinks that there's some rules somewhere that you have to do something a specific way, and so they never stop doing it. Right. And so like even in the interoperability world, we're fighting with Epic in some local jurisdictions because Epic thinks they have to e-fax even when they do ECR. And they will not turn off e-faxing. And we have to keep it. And so at some point we want to link, I think, the policy and communications with decommissioning. There's gonna be a lot of people that think they have to keep doing what they've always done.
Great. Yes, Fran.
Two questions. Great presentation. Really, well, depressing, but good.
Lots of opportunity.
Yeah. So the first one, to pick up on what you just said, Craig, one of the things that you mentioned right at the outset was what a barrier DUAs are, data use agreements, right? They're just such a pain. But how much of those are actually, I get FERPA, I get HIPAA, but how much of those are actually legal impediments, or are they policy, like traditional norms? You know, so a lot of times when you unpeel that onion, there's not always there then. So I guess it's just a general observation for be skeptical if somebody says you can't do it, because it's really just because we haven't done it before. So anyway, that's just that. I'm so happy you led this thing off with a slide about the AHEAD model, because here's why. We want much more integrated systems across clinical health and social services. We want behavioral health. We want it all for public health purposes. But if public health is the only customer demanding that, we're going to have a long wait. But head model, these health systems are starting to say, holy cow, we have to figure out what is the immunization rate in these zip codes for pneumococcal pneumonia, because we're readmitting them too often to our hospitals. So they're going to have to look at EPIC. They're going to have to look at CRISP. They're going to have to look at the immunization, the Immunet, whatever that registry is. And they're going to find that it's a kind of a chaotic mess, and they are going to apply their horsepower as significant users to fixing this up, whatever that looks like. So my only point here is to say that a public health collective around data would be good, but a population health, to get the health systems involved in that in Maryland, would be even more powerful. So I just have had experiences with Craig where we wanted something done in the pandemic. We needed to have how many nursing home patients are, spike an attempt tonight. I mean, that was nursing homes to try to get into CRISP. Oh my God, that was crazy. But they actually did it. They did it like within weeks, right? And so how are we going to get an opioid crisis? How are we going to monitor when docs are writing opioid prescriptions? Well, we're not going to do it like Mina knows. We're not going to do a standalone prescription drug monitor. We're going to do it through CRISP. So anyway, my point is that we need to think across the whole healthcare delivery system as well as public health as far as our common data needs. So just thank you for starting with the AHEAD model. I hope the AHEAD model survives. Okay, and that's something that's beyond me.
I appreciate your comment, and I think of what we do as a tricycle. There's three wheels, and you have public health, social services, human services, and healthcare. And you have to have all three wheels to drive forward. And the connection between those, like all the tubes that connect them, is the tools we use. And one of those tools is the HR systems and the way we send data back and forth. So I'm 100% on board with this. Has to be a whole system. It can't just be public health, because then we're going to lose all this other all this other data and the ability to communicate with each other most effectively. And I'll give you just a personal example. We want to understand if our crisis stabilization center our crisis system is reducing ED use. And I've got agreements to give you the data, but the idea of them going and polling and there's so many steps and layers to getting just that report done that it's a lot of energy, unnecessary energy spent. If we could create a system that allowed me to go and just see what that looked like in an efficient manner, and this is perfect world, right, which we don't live in, I could get a lot more done more quickly and be able to adapt my systems to meet the needs, or look and see it's not working, but that's like a real world example of what we could potentially do. So, but thank you for your comment. That was
Great. Nicole?
Yeah, thank you. That was great. My question ties into what Fran was just saying in terms of the kind of the data sharing. I don't know if this is still the issue, but I remember not too many years ago, there were challenges with sharing information among clinical enterprises and the human services, such that, while there are all these requirements and there's Z codes and there's ways that, healthcare providers, clinicians are being encouraged to not just identify social drivers of health, but then make the appropriate referrals. But there were concerns and challenges with being able to share that information, then the provider knowing, did my patient show up for this appointment? What was the outcome? So there wasn't closed loop communication, and there were concerns about privacy and the patients needing to explicitly opt in. And so is that, if that's still the current environment, I just wanted to put that on the table to make sure that your work group is, that gets addressed in our recommendations.
I love that question, Craig.
Well, so no, there's good news and bad news, right? So the good news is that technically that's less of an issue. Okay. Closed loop referrals exist, interoperability exists, consent exists, like that's all available as a system. We're seeing other barriers, so like Z codes. Some health systems are very good at documenting Z codes, some don't do it all. And I think just generally there's concerns like, well, how accurate is any of the data, about social care within a healthcare, within a hospital, right? It's just not a great environment to spend that time. Mm-hmm. And then we're also seeing that the policy and funding mechanisms for CBOs and for social support hasn't changed. So you send a referral, it doesn't get closed. Well, it's because they already have that referral, right? Like they're busy. They don't need another referral. So I think it's more of a kind of a top-down system issue. But also I know like Elizabeth Crum and I'm sure Dr. K are all like they're focused on health-related social needs. So I know MDH is talking about.
And one thing I would just add to that, you also you have the code, like for example, counsel for physical activity or nutrition, but you don't actually know what they did. So if you're looking at the code, it's saying they did it, but then you don't have a standard behind that to say what it means. So you have a variability. Now we can't fix that piece.
Yeah.
But unless through training and education, but we have a standard here that we might be able to put in place, but we don't know what they actually did. And some of them would have, maybe did motivational interviewing. They sat down with the patient and they set up a schedule, and some of them said eat more vegetables, and they coded that it was, So I think we also have to keep that in mind, that the data is we don't have a way to, well, we do have a way to connect it all because we have CRISP, but we don't have a way to necessarily understand it yet, what it means.
Yeah.
Other questions in the room? Questions from commissioners first online. I know, Rosalie, you have your hand up. I'll get to you in a tiny bit if we have no other questions from commissioners. Okay, I will allow Rosalie, since she's been such a member of our community here. Rosalie, please.
Thank you. Yes, I know the rules. So I was wondering, when you were talking about the difficulties of trying to get the resources together to improve IT for the state, there must be other states in a similar situation, and they have similar needs, similar environments, not exactly the same. But is there room for collaboration that will help save on the expense of expertise and design? May be able to work out some quantity discounts on hardware, et cetera, as well. That's my main point.
Yeah, it's a great thought. On the kind of multi-state idea, there's a lot, and the CDC Foundation, ASTO, FAB, there are a lot of groups that are helping to guide kind of multi-state, centers of excellence and all sorts of. So I do think that exists. And actually CRISP is a member, is an implementation center within those series of programs. So we do have some expertise there. I think that it's still hard, like every state is still different, which is wonderful, right? So state control and state authority. I'm not sure, and this is, you all probably can speak to better than I can, how much, if the CDC puts out kind of guidance around North Star architecture for public health data systems, which they have, I'm not sure how many states read that and think, we got it, and start marching, right? Like there's still just so much nuance at the local level. So I think the guidance is very helpful. I still think you probably need a group like this to then say, okay, of this guidance, what makes sense in Maryland or any state?
Thanks, but I would caution on continuing to rely on CDC for anything going forward. So the states need to figure out how to be independent of the CDC and still be effective.
Great, thank you, Rosalie. Any other hands being raised in the room? Okay, Dushanka, yes.
I'm just going to raise one other issue, piggybacking on what Fran said about getting the asthma information and everything else, and sort of looking at the entire system. In terms of program evaluation in the public health arena, where we're implementing evidence-based interventions, some of which are, participatory training, orientation, I think what kind of systems need to be augmented in order to get to the type of detail where we would get a true assessment of these individual programs, and then probably accumulation or combination of activities that are being done, the clinical, the psychological, the physical component, nutritional component.
So your question is, what kind of system do we?
No, what kind of are you considering systems in the data IT area that would actually branch out into these areas and have a consistent feedback mechanism of program evaluation that's routinized, the quality improvement process of the conduct of the sort of like the delivery of the programs?
I mean, I think I'm not a program evaluation expert. One of the things we struggle with is having the data even across all those dimensions still makes it hard to then analyze the data to determine the efficacy of any single intervention. But we'll make sure to kind of include program evaluation as a framework, so then smart people can say, well, this is how I would then use that data, these kind of different things.
I think just to add to that, some of the systems do those pillars of health, the physical, somatic, behavioral health, mental health, oral health, nutritional health. They organize the data fairly well to be able to pull out, it's garbage in, garbage out. So if you're not putting the data in correctly, you can't pull a good report. Although I don't know if that they translate. You have making a really good point. I don't know if that they you take that data and you can put it in RedCap or some other database that actually does more research and analytics. Some of the systems, some of the bigger stable systems have an analytics component to it, and then people that have been licensed to do the analytics for some of the systems. But from a research perspective, I don't think we have a really good way to take that data and then translate it easily to a system that then can help us. But we'll look into that. That's a really good point.
It also, just to be a little bit doom and gloom, it also then goes back to the data use stuff. Because like we can export into OMOP, so research can do all sorts of great things, but only if the tail of who's allowed to use what data for which purpose is consistent and governed.
Okay, great. Do we have anybody else? Did you?
Just Amelia made a comment.
Oh,
so
Amelia
it's-
made a comment online. Okay.
Yeah, she said if we can link services to outcomes, we can evaluate it.
If we can link service to outcomes, we can evaluate.
Yeah. Okay, well, great discussion. Thank you all for participating so well. Any other business before we move to adjourn our meeting?
I have one really quick.
Yep.
It was announced we will have a new secretary at MDH come April.
Yep.
So we can get her on the schedule and invite her to come.
Yeah, that certainly is on our list. You know, the situation, obviously, and we didn't sort of cover this, but I assume the commissioners, maybe not everybody knows, is that Laura Herrera Scott is leaving her position, I think, at the end of this month. Then we'll have an acting in place until April, I believe, right? And at this point, if you check in online, you'll see all the names of everybody who's coming in. We'll be working with Nilesh, who's in serving in the deputy or in the deputy secretary role in terms of making sure that this is briefed up. The commission is being briefed up to both the acting position and to the person who comes in ultimately. But you're absolutely right. We will reach out to make sure that the new secretary will be briefed up, not only briefed up, but will be invited here in the future meeting. Good point. Okay, any other business? Yep. Mm-hmm. So at the same time of thanking you all, I will ask for an adjournment or announcements. Basically, next monthly meeting is Thursday, March 13th from 2 to 5 in this very location. Tosin will be the presiding co-chair. I think you've had enough of me. We had issues with our rotation. And the way I look at it, I think I did the special meeting in December and the January and the February meeting. So I really enjoy doing this, but I do want to share the joy of being the chair with others, and Tosin and Nina will be back into the rotation. We also do remind you, and Shane already did this, but make sure they're in your calendars. I know we're pressing hard on the commissioners with those extra meetings, but we're all set up for March 13th, our next regular meeting, April 3rd, our next regular meeting, April 15th, tax day as a special meeting so that we can unfold our work. May 1st, our regular meeting, May 20th, as a special meeting, June 5th, July 10th, August 21st, and September 11th. So make sure they are on your calendars, because don't forget, we're ramping up, right? And ramping up means a lot more vibrant discussion in this room, starting to focus on this idea of the recommendations and the process that's going to unfold. So that being said, I ask for a motion to adjourn this meeting here today. That's Fran, and then Nina, I'll take yours. What's that?
It was Nicole.
Oh, it's Nicole. Okay, Nicole, and then, sorry, I looked at the correction and I heard a voice out in the desert. Right? Do we have a second?
I think Mina.
Okay, Mina seconded, and so therefore, let's all vote. Who wants to adjourn this meeting? Okay. Who wants to stay longer? No, anybody abstaining? That being said, I don't have a gavel, but with my fist, great meeting, folks. Thank you all for your dedication.
Thank you, Boris.
Thank you. Take care.
Nice job, Stan.
For treatment program.
Thank you, everyone.
Thank you. Business before and after.